Honorable members, it is 10:15. Welcome to all of you. Welcome to our staff and officials, and welcome to members of the media. Welcome to our presenters to this meeting, which is a continuation of the NHI Bill public hearings. We also welcome the PLO of the Minister of Health, Mr. Joe Cutler. And I would think that our Deputy Minister will join us a bit later. So, Ms. Majalamba, can I just get attendance and apologies, please?
Good morning and thank you, Chair. Present is Dr. Jacobs, Mr. Munyayi, Ms. Geller, Mr. Sokacha, Dr. Harvard, Ms. Ishmael, Dr. Tembekwayo, Ms. Chirwa. I've received apologies from Ms. Sukers and Mr. Imam Sheikh. Thank you, Chair.
Thank you very much, Ms. Majalamba. I had a call from Mr. Van Staden, who will join us, Honorable Van Staden, who will join us a little bit later. So let's just note his apology for the morning session, or early morning session. Honorable members, as I already said, that this is a continuation of the NHI public hearings on the NHI bill. I welcome you all as you had logged in again. Let me just remind you that this is a virtual meeting that is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of the debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons at the bar, on the bar at the bottom of the screens, which has an option that allows a member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairpersons to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. Today, we will receive presentations or oral representations from Germs Medical Aid, from the South African Medical Research Council, and specifically the Alcohol, Tobacco and Drug Research Unit of the SAMRC, from the National Planning Commission, and from Scalabrini. Excuse me, Honorable Munyayi. I see that you had raised your hands on the platform.
Thank you very much, Honorable Chair. I want to appeal that what has happened yesterday should not happen. We should not allow the administration to invite people that have presented before, because that will put us into serious disrepute. I can't get it as to why, as a matter of principle, why the same organization would be allowed to present twice. And I've not yet received any apology from the administration. Can you please make sure, Honorable Chair, that no organization that have presented before this oral public hearing should be allowed or should be invited to present twice? It should not be allowed. Thank you, Honorable Chair. If you can emphasize that point, because we can't work like police, try to scrutinize everything. If we would have allowed the PPS to present yesterday until the end, and were taken to court, that we are allowed to a same organization to present twice. Why the others could not be allowed? That would put the parliament process of NHI into a very precarious position. I thought as a matter of principle, Honorable Chair, this should be avoided at all costs. Thanks.
Thank you, Honorable Munyai, for that input. I had followed it up and I had given a reason yesterday, which was that there were two submissions made and it was just an error on the side of the decision made to invite, because there was an assumption that those would be two different presentations. But be that as it may, the same would hold today for the SAMRC. And that is why I made it very clear that this is a different unit of the SAMRC, which is the Alcohol, Tobacco and Drug Research Unit, which would make a completely different presentation, the SAMRC being a very large organization. And even though it's mentioned under the umbrella of the SAMRC, it is not like yesterday's meeting where it was the same presentation being done for a second time as noted by your good self. So thank you very much for that. So honorable members, I have now, we also for today have a postponement request from the medical deans, and which we had allowed, and we will probably have them next week, Wednesday, if that is agreed upon a date for the presentation. And having that said, we have Germs on the platform. They will be led by Dr. Stan Molowabi. Dr. Molowabi, you're very welcome. Please, let me also remind all of you to please switch on your cameras when you are all speaking, including the members and all of our presenters and those raising anything on our platform, because we do have live broadcast today on YouTube, Twitter, Facebook. We will have a delayed broadcast on the parliamentary TV, and we have it being published on the IONO website. So thank you very much. I see you've already flighted your presentation. Dr. Molowabi, you can also introduce your team and go straight on with your presentation. Thank you.
Thank you, Chairperson of the Parliamentary Portfolio Committee on Health. May I at this stage request that the Chairperson of the GEMS Board of Trustees, Dr. Millicent Tlatswayo, will be the one who leads us, and then I will follow after her. Dr. Tlatswayo.
Thank you so much, Dr. Molowabi. Chairperson of the Portfolio Committee on Health, Dr. Kenneth Leonard Jacobs, members of the Portfolio Committee on Health, fellow board members and executive of GEMS, ladies and gentlemen. As Dr. Molowabi has alluded, that I am Dr. Sibaitseng Millicent Tlatswayo, the chairperson of the Government Medical Aid Scheme. I'm here to present them on this presentation and thereby express our gratitude and appreciation to the Parliamentary Portfolio Committee on Health for this opportunity to present our input to the National Insurance Bill for consideration. The NHI Bill constitutes a momentous piece of legislation which we, in principle, unequivocally support. Inequality in South Africa is so stark and widespread that we are referred to as one of the most unequal societies in the world. The source of the inequality that plagues South Africa is multifaceted and largely due to past social injustices. Inequality is worst in health, and central to this is the inequality in healthcare financing between the public and the private sectors. The public health sector has challenges of limited access due to shortages of healthcare workers, infrastructure, and medicines, as documented in the NHI white paper. The private health sector has challenges in respect of affordability and sustainability as articulated in the Health Market Inquiry Report. The right to life, as enshrined in Section 11 of the Constitution of South Africa, is intertwined with the right to access healthcare and equality of enjoyment of this right for all citizens, as enshrined in Section 9 and 27 of the Constitution. It is imperative to implement the national health insurance with a good governance structure and measures to prevent corruption, fraud, wastage, thus ensuring that these rights are enjoyed by all citizens of our country. As GEMS, we are proof that intentional redress of past injustices is possible. Prior to the establishment of GEMS, many public service employees were excluded from medical schemes coverage because of both the lack of resources for funding and access to health services in the previously underserviced areas. Almost 20 years ago, the Cabinet approved the establishment of GEMS to promote equitable, efficient coverage for previously uncovered public sector employees, therefore advancing the protection of the rights alluded to above. In line with the PSCBC Resolution 1 of 2018, GEMS and the PSCBC co-created the Tanzanite 1 option, progressively expanding the access to health services to beneficiaries. The average after-subsidy contribution per family of Tanzanite 1 is only 95 rands. That is less than 100 rand to cover a family. Tanzanite 1 members are the most satisfied group within GEMS, with satisfaction levels of 95%, indicating that affordability is key to access to healthcare. GEMS has successfully expanded coverage to 2 million beneficiaries and have the widest definition of a beneficiary, which allows cover for up to 5 generations in a family. Keeping our members foremost in mind, good governance has been consistently demonstrated in low, non-health expenditure, conservative, unqualified audits since inception, and healthy reserves. Since the implementation of the NHI policy, aligning the GEMS operating model with the NHI principles has resulted in reduced healthcare expenditure and improved member-provider satisfaction levels. Key to the success of GEMS is risk pooling. Risk pooling is a means by which funds are pulled together according to their ability to pay and use by need. Effective risk pooling requires that high-income earners cross-subsidize low-income earners, the healthy cross-subsidize sick, and the youth, the aged. GEMS has tested this model. Members pay
Sorry for the interjection. Are you using your slides at the moment? Because they have not moved.
No, I'm not using any slides. It's just an overview, and then our PO will be able to go through the slides.
Thank you. I assume so. Thank you.
Thank you. Members pay according to their income bands. Pensioners are defaulted to the lowest income band to enable them to afford membership with a medical scheme, particularly at a time when healthcare services are required the most. Thus, we have effectively demonstrated that risk pooling is possible and sustainable in our country for all South Africans. NHI can be implemented more efficiently and effectively by leveraging the existing structure and expertise within GEMS and the medical scheme industry. GEMS is well positioned to make a meaningful contribution to the healthcare industry with the long-term goal of NHI being successfully implemented. We are here to lend a hand. In summary, we express our unequivocal support to eliminate socio-economic injustices, heal the divisions of the past, and establish a society based on democratic values, social justice, and the realization of human rights as enshrined in our Constitution. The rights to equality and dignity, the right to life, and the progressive realization of the right to access healthcare services. We must take concrete steps to ensure that all South Africans receive the health services they need without suffering financial hardship. On behalf of the collective leadership of GEMS, Again, we thank you for this opportunity to present our inputs. I will now hand over to our PO, Dr. Stan Molwabi. Our submission will outline the following key issues. One would be the key area on the Nhi Bill, Germs view and evidence of support, and Germs overall recommendation. I thank you, Chair, and I will hand over to Dr. Molwabi.
Thank you very much, Dr. Hlatsoyo. The chairperson of the board. May I again say good morning to the chairperson of the Parliamentary Portfolio Committee on Health, to the members of the committee, members of the board and colleagues and everybody else who is listening today. I thought we should start our presentation by just restating the GEMS mandate, as the chairperson of the board has already alluded to that. In 2002, and the chairperson said about 20 years ago, the cabinet approved a framework policy on the establishment of a restricted medical scheme for public service employee. And the mandate that was given to GEMS by the state is that as an employer, the state sought to ensure that there is adequate provisioning of healthcare coverage to public service employees that is efficient, that is cost effective, but more importantly, that is equitable. Prior to the registration and the commencement of GEMS as a scheme, there was a gap in the health funding industry. Government, who subsidized the public service employees scheme contributions, had no opportunity to participate in the oversight of the medical schemes to which these employees belonged. With GEMS, 50% of the board is appointed by the employer, government, and 50% is appointed or elected by the employees who are members of GEMS. It is very significant, and we need to state this, that with the board oversight, GEMS has been successful in increasing coverage for those that were previously not covered. Over the years of its operation since inception, GEMS has posted 14 consecutive unqualified audits. And in 2021, in the past year, we are again upgraded by the Global Credit Rating Agency to a rating of AA, which is one of the high ratings. I just thought we should share with the committee a snapshot of GEMS as at the end of 2021, which is the last reporting period. These figures that we are sharing today are still undergoing an audit. In terms of principal members, GEMS covers more than 770,000 members. We cover over 2 million beneficiaries. The annual contribution income for GEMS is 46 billion, of which in the past year, 42 billion was used towards paying for the healthcare needs of the GEMS members. GEMS posted a net surplus of 4 billion rand in the past financial year. The reserve ratio, we ended the year at 46.10. The statutory requirement is 25%. Importantly, the non-healthcare expenditure of GEMS has been kept very low. In the past reporting year, it was 4.5 when compared with an industry average of 8.6. Our presentation today, Chair, and our submission is part of a democratic legislative process. And we are stating that we support and we are honored to be part of making inputs into this legislative process. We all know the definition of the national health insurance. We've been dealing with this for quite some time. However, from a GEMS point of view, we needed to just restate that the main outcome of establishing the NHI fund is desired to be creating a single risk pool for the country. This will result in a risk pool that is large, 60 million as opposed to about 9 million beneficiaries who are currently insured. That large risk pool will be a pool that has a diverse risk mix. That means both the sick and the healthy will become part of that risk pool. And importantly, it will be compulsory to be part of that risk pool. And what is the intent? It's simply to address the barriers of access to address the barriers of access to healthcare. Germs supports the establishment of the National Health Insurance Fund in order to address the barriers of access to healthcare. Those barriers are as a result of the current two-tier healthcare system, which is, as we know, made up of the so-called public health system and the private healthcare system. And the end point here is that the implementation of NHI is moving the country towards universal healthcare coverage, which allows for pooling of resources, which provides for income cross subsidies. And at GEMS, our structure of contribution is already structured on income bands. There will be risk cross subsidizations, the healthy subsidize the sick who access the healthcare services. NHI is a vehicle for us as a country to achieve universal healthcare coverage in South Africa. And we know there are countries which have already asked, using the system, they have achieved universal healthcare coverage through similar models. And the one that is really quoted most of the time and best known to us is the UK NHLS model. We believe as GEMS that effective risk pooling is a means to reduce gaps and address the health disparities amongst us South Africans. And we support the establishment of NHI fund as a means to achieve universal healthcare coverage. The NHI fund implementation cannot be achieved without creating a single common fund, which will contribute towards a unified healthcare system, which will improve equity in financing. It will reduce fragmentation of the funding pools that we currently have, the large ones being public sector and private sector. And it will make healthcare delivery more affordable, more accessible to the entire population based on healthcare needs and not on the ability to pay as it is at the moment. The NHI Fund is founded on the principles of social security, social solidarity, and equity. And this allows for universal access, mandatory payment for healthcare services, the receipt or access to comprehensive healthcare services, but as an important part of universal healthcare, financial risk protection. Families need to be protected from the catastrophic events of health, which can basically bankrupt families. It will be a single fund, so it will be big enough to enter into strategic purchaser arrangements and a single payer of healthcare services that are accessed by its members. There are sections of this constitution that link with the NHI. But I think the most important one, as we all know, is Section 27, which I quote, "Everyone has got the right to have access to healthcare services." And you know that the state must take, it further obligates the state to take reasonable legislative and other measures within its available resources to achieve progressive realization to each of these rights. And we know that the other sections also allude to issues like the right that every child has to basic healthcare services. And this was implemented by our first democratically elected president, Nelson Mandela, in 1994 when he ascended to the presidency. The afforded right as a basic right to children. There's also under Section 28 the rights the subsequent sections that are relevant, which talk to the rights to human dignity and the right to bodily and psychological integrity, which has become so important for us. There are also linkages to the international conventions, and the ones that we want to draw attention to are Article 12 of the United Nations Covenant on Economic, Social, and Cultural Rights, and Article 16 of the African Charter on Human and People Rights. So what are the principles of national health insurance? It has to afford the right to access to health. It must achieve social solidarity and equity. It must avail health care as a public good. It must be affordable, efficient, effective, and the healthcare services that are rendered to the beneficiaries must be clinically appropriate. So these features and principles of the NHI, as expressed in the bill, they support constitutional rights, they support international conventions, and we are fully supporting them at GEMS. In a nutshell, the NHI bill, when enacted into law, it will establish a fund that is an organ of state. It will define the functions, powers, and obligations of the fund. It will establish a board with clearly defined responsibilities. It will define who are the beneficiaries of the fund, and it will seek to contract accredited healthcare providers. It will also importantly define the benefit entitlements. And lastly, because this is a legislative process, through the schedules, it will amend applicable sets of acts or law to enable the implementation of NHI. So when the act is signed into law by the president, it will establish a national health insurance fund, which is a single purchaser, single payer of healthcare services, which pools the funds to enable it to do all its obligations. And in terms of application of the act, like any act, there are stated restrictions or limitations, and hence it will not apply to the military and the state security agency for obvious reasons. It will also not be subject to the Competition Act, and I think that it is to make it affordable as possible. An important aspect of this whole process is that there must be promotion of access to healthcare services. And all South Africans, permanent residents, refugees, and the list is much bigger than that, are amongst those that are specified in the bill. So the intent is to cover everybody in the country who qualify. It is important to also state that it enables the fund. So the act, when it is signed into law, it will enable the fund in consultation with the minister to purchase healthcare services, and these healthcare services will be defined in the benefits as determined by the Benefits Advisory Committee of the fund, which is one of those committees that will have been established in terms of the provisions of the Act. It will be important for anybody to access the healthcare services on registration. And it is important that people should be aware that they need to register to become beneficiaries of the NHI system. And we support the registration of users of the fund, as it will be one of the the ways to obviate or mitigate fraud, waste, and abuse. And the process of registration of users is clearly outlined in the bill that will become the act. But again, it is important to stress that this process is not intended to exclude people who qualify to be on the beneficiaries of the of NHI. It is intended to monitor, to also to reduce the opportunity of fraud, waste, and abuse. So the type of healthcare services that beneficiaries must have access to is quality health services that must be obtainable, free at the point of care. The people must have access to information about the fund. They should not be refused access on unreasonable grounds. There should be access to care within a reasonable time frame. The reasonable decisions about the person's health must be taken by those that are in authority, and there is provision from a complaints process to be able to purchase healthcare services that are not covered by the fund. The medical schemes are set, as stated in Section 33, to have a complementary role within a regulated environment, which we are already operating in as medical schemes. So this section actually adequately protects the rights of users, and when benefits are clearly defined, members will know, or those who qualify as beneficiaries will be empowered to complain if they do not, if their expectations are not met. It is important for one, if one is to access healthcare services, one must know what are the healthcare services that are covered. So it will be all those services that are purchased by the on behalf by the single purchaser on behalf of all beneficiaries. The providers need to provide a registered service of accredited service for them to be able to transfer in a referral systems. The entry level of healthcare, ideally, and this is restated time and again, is at the primary healthcare level. And then there should be referral pathways that are determined based on protocols for one to access secondary and tertiary healthcare services. So the minister, in terms of the bill, will designate central hospitals as part of the government, as they are part of the government. There are protocols which will guide on treatments that are not funded, usually due to not medically necessary, or those that are not cost effective, those that are not included in the formulary. And it is important that if there is an appeal process that will follow, reasons will be provided why such was not given. So our position at GEMS is that we support the determination of healthcare services by the committees, in this case, the Beneficiary Benefits Advisory Committee in consultation with the board. There is a need to build a high quality and effective public healthcare system that will be the delivery platform for the entry level of the healthcare service. And this PHC service delivery should be inclusive of the entire population located within the district health management offices. Delivery of services must be done in a comprehensive and integrated manner. And we have at GEMS, because our principle is government, we work with the various departments, the Department of Public Service and Administration, and the Department of Health. And in those interactions, all issues like corruption are dealt with from a governance perspective, and the role of government, in this case the minister, as the executive authority, is recognized. In terms of primary healthcare, the aim is that it should be affordable, It should be sustainable, and it should place an emphasis on health promotion and preventative care. There is a need to establish high-quality primary healthcare services as the foundation of the healthcare system, and the reintroduction of gatekeeping function using the primary healthcare services. In our environment, we refer to this gatekeeping function as care coordination, which involves nomination of the healthcare providers that you use, a referral system at the level of primary healthcare to be able to access the specialist. So ordinarily, except in emergency, beneficiaries should not use specialist healthcare services. That results in over-servicing of those services and more higher costs. The use of primary healthcare must be the entry level of healthcare. There are those stipulated functions of the fund. I'm not going to go through them, but they guide how the fund will be established specifically as an organ of state. It will be classified under Section 3A as a public entity. The Act will then afford powers to the fund, which will be able to establish a structure, employ personnel, acquire assets so that it is able to be run. And then there are various other business imperatives that the fund will be obligated to execute. In terms of a section of the NHI bill, there will be establishment of a board which is accountable to the minister, and the details are specified in that section of the Act. The NHI bill also stipulates the functions and the powers of the board, and importantly that as required by the Public Finance Management Act and other acts, there will have to be compliance with those attendant acts. There will be a need that the board members are fit and proper. There is a need to disclose their interests, and where conflict exists, it must be declared as well. The board will determine its own procedures, policies that it will operate on, and there will be the remuneration and investments determined between the Minister of Health and the Minister of the Treasury, Minister of Finance. And any roles that are stipulated for institutions and functions that are not covered may be provided for, as it is normal with other acts in the regulations. The accounting officer of the fund will be the Chief Executive Officer, and the process and the requirements are stated in that section that deals with the appointment of the CEO, and then the responsibilities are mainly that the CEO accounts to the board, and the other functions are also stipulated in the bill. There are committees that will be established. There are several of them, and there will be technical committees that may be established by the board, but some of those that are stated, which are of significance, not that they are more important than the others, the Benefits Advisory Committee, which determines the benefit entitlements, the Pricing Committee, which will determine things like tariffs at which the NHI will pay healthcare providers, etc. There's also a Stakeholder Advisory Committee, which should be established in terms of the bill, and all of these will be supporting the board in executing its responsibilities to the entire countries. There are also general provisions which stipulate the role of the minister in terms of being the one responsible for governance and stewardship of the fund. And it will be important, and I think this is catered for, that the minister will delineate the roles and responsibilities of both himself or herself and the fund. And as we know that we are part of a three-tier government, and what will be the responsibility at national, at provincial, even at the local government level. There are also the other acts that are existing that basically will also supplement some of the functions that are stipulated in the NHI bill. And this will deal with guidelines to the norms and standards that needs to be adhered to, the human resource planning and development, coordination of healthcare across the 3 tiers of government, planning and development of health establishment, and all the other responsibilities attendant to the establishment of the National Health Insurance Act. There are some governance features that are stipulated in the Act, but we needed to state again that the minister, as we know, is the executive authority. And this is because national health is a responsibility of the Minister of Health. Hence, he has the overall executive authority. However, in the context of the establishment of the NHI bill, the establishment of the board and various advisory committees is consistent with good governance. And I think there's been...
Point of order. Yes, please, Chair. I'm so sorry to interrupt Mr. Malawabi, but at the moment we're getting a presentation on the NHI bill. We are the portfolio committee. We know exactly what is in the NHI bill. In order to save time and these presentations, and we've got a lot still to go, is it possible to get to the crux of what Germs wants or doesn't want, or the recommendations? We know what the NHI bill is. We've been dealing with it for several years already. Perhaps in interest of time, we can get to the nitty-gritty of Germs' proposals or disagreements. Thank you.
Thank you, Honourable Wilson.
Chairperson.
Give me a moment. Honourable Wilson, thank you very much for your input. But I would guess that the 45 minutes, how they use it is really at their own discretion. I would think that Dr. Malawabi would note what you've just said, but I don't think it would also be fair for us to dictate to them what they ought to be saying within those 45 minutes. So I'm going to overrule that view of yours. Thank you. Continue, Dr. Malawabi.
Thank you, Chair.
Thank you, Chairperson. Thank you, Chair. Basically, I have noted that input, and in no way when we restate, Chair, are we saying that members of this committee are not afraid with the Act. The intention is to indicate areas where we support, and we have also a written submission that we have done, which contains any other things that may not be in this presentation. And we basically had to manage the time that is allocated to us, as you rightfully said, so Chair. So Chair, in terms of governance and controls that are provided for in the bill, we basically noted that there is a narrative that state-owned entities are always run badly, but that's not entirely true. At Germs, we are an example of a well-run state institution where the employer, represented by the Minister of Public Service and Administration, appoints half of the board. And this is also provided for in that section of the bill. And it makes provision for the minister to consider representation from the board in terms of this section. And good governance has always been a very important thing at Germs. The members of the board are affiliated to institutions like the board of the Institute of the Board of Directors, informed by King from a governance perspective. Chairperson, I think section 33 of the bill has received a lot of attention, and it talks to basically the role of medical schemes once NHI is established. And our view is that through once the benefits that are available in an NHI environment are determined through regulations, then the medical scheme can then be afforded that complementary role that is often referred to in terms of what it can do to basically close that gap. So in terms of this section that has received quite a lot of attention, and rightfully so, because certainty is also needed on the side of the medical schemes. We appreciate that then there will be guidance through the regulations based on the benefit entitlements that will be available in an NHI environment. And usually these benefits are introduced on an incremental basis. And one would imagine that that will be the approach also in an environment. The transitional arrangements, Chair, are very important for us to be able to manage the transition from the current status of how healthcare is funded in the country to where we will be through the phases that we needed we will go through until the full implementation of the bill. Chair, in summary here, I'm giving an overview, and then this talks basically to the point that was raised by the honorable member earlier on in a form of question. Our position as GEMS is that we know that there are about 59 sections of the Act, and in terms of this legend that is before you, the green ones are the ones we fully supported. We didn't comment on those, and then we basically on the blue ones there were some comments which are in the basically in the write-up where we are basically making some minor suggestions, and then the gray ones. You should not be perturbed, committee. These are the ones on which, in our submission, we will have suggested largely enhancements, which are to be considered through this process for this whole process to be to continue, Chair. So, in conclusion, Chair, the implementation of the National Health Insurance Fund will strengthen the attainment of universal health care coverage. GEMS supports NHI principles and embraces principles of social solidarity and equity. And these are some of the pillars of distributive justice that we so much need in the healthcare environment. GEMS unequivocally supports the bill, and every aspect of our presentation covered the content that we align with the key central aspects of the bill, and the content and the spirits of what was contained in the speech by the chairperson of board in her opening remarks were also aimed at supporting the bill. Chairperson, I think I should just finish by just stating that over the years that GEMS has been running, and I have stated earlier that we have had 14 unqualified audits, we have achieved a number of accolades through our relentless pursuit for excellence. We are one of the top employers 2022. We are also taking into consideration the imperatives of our countries in terms of BEE development. We have a program of supplier development, and we became a finalist in the past year. Out of more than 400 entrants, we are among the top 15, and we really value the work that has been done towards advancing broad-based economic empowerment. We are a risk-averse organization, and we implement risk monitoring in everything we do. And we were awarded 2 consecutive years, 2018 and 2019. We have an award from the Institute of Risk Management, having been assessed for our risk management practices. We also have the Titanium Awards, which is a recognition by the Board of Healthcare Funders in recognizing excellence in healthcare. And this award was about creating access to healthcare, which we demonstrated. And then we also protect the environment as a responsible citizen And the building that Germs owns is a 5-star green building. And then the last accolade there, the bottom left, right, we were upgraded to an AA with a stable outlook by the global credit ratings, which demonstrates a very strong and high ability to pay claims. Chairperson, we thank you very much for the opportunity to present to the committee. And as I indicated, we have made a written submission which has got more detail than what I have presented here. Thank you, Chair.
Thank you very much, Dr. Molwabi and Dr. Flatswayo. Also, thank you very much for showing all the good work that you've done in terms of the accolades which you have received. We appreciate you bringing this presentation to us and presenting to the Portfolio Committee. There are a number of members who want to raise some points with you, and I'm going to name them in order of, as I have been given these names, and thereafter I will take the hands which are raised on the platform. It's Honorable Stembakwayo, Ismail, Gela, Clark, Wilson, Sukacha, Munyai, Van Staden. Stembakwayo, Ismail, Gela, Clark, Wilson, Sukacha, Munyai, Van Staden. Honorable Gela and Munya, in that order, are those, is that a new hand of yours, Honorable Munya? And then Honorable Gela, I see you've raised your hand.
It is a legacy hand. Thank you.
Okay. And Honorable Gela, you've also lowered your hand. Thank you. That's the order, Honorable members, for you to raise your concerns and questions with the representatives of GEMS. Please proceed.
Thank you, Chairperson. And can I proceed?
Yes, please do.
Yes, thank you, Chairperson, and thank you, James, for your presentation. But as I was listening to this presentation, it seems to me as though James has been promised to run the NHI, and it strengthened the need to ask this question. But creating first the scenario from the overview as it was presented by the doctor, where she said she specifically stressed good governance, and it was also echoed by the presenter now, that they usually use the good governance as their exit point. It is alleged that GEMS, as you are positioning yourself to administer the NHI, yet you have been rocketed by allegations of tender rigging, fraud, maladministration, and corruption totaling more than 300 million. That is reported in 10 explosive forensic reports, which showed that over a period of 5 years, the scheme had appointed and paid that particular money, more than 300 million, to companies in which some of each executives had direct financial interest. Can you come clean on this matter, James? Because if truly you will be appointed by the government to administer NHI, then you will obviously lead the NHI to crash under the weight of corruption, like many other state-owned entities. Thank you, Chairperson.
Good morning, and thank you very much for your presentation. I have a number of questions. Now, you've stated over and over again that, the funding will be very good, and you actually agree with universal healthcare, and you feel that the NHI, once implemented, will be providing a good and effective healthcare services to the country. Now, in your opinion, do you really feel that this bill will allow for equal access to quality healthcare, considering that as we see the country right now, if it wasn't for the private sector, our healthcare system, our citizens, our residents out there would not be receiving healthcare services in the first place. We know there's a shortage of healthcare workers. We know that there's a budget shortfall in placements of doctors and nurses. We know that our infrastructure is a problem. So would you really say that the NHI bill in its current form will be providing a health value-based model and that the bill will be sustainable in its current form? Now, my second question, noting that the NHI will be sourcing funds from taxes, and we know the tax base in South Africa is relatively small due to the unemployment crisis that we have, do you feel that the pool of taxes will be sufficient to carry the bill, since presently the private sector is in the forefront in assisting with health services to the country? My third question, do you feel that, before the NHI is implemented, the Department of Health should actually concentrate on the upgrading of infrastructure and concentrate on the placement of healthcare workers, so that, when the time comes, we actually already have the necessities in place? I see in your presentation you're quite aligned in most of your discussions to say that you definitely agree with the NHI and you feel the NHI will be providing equal access to healthcare. But if we don't have the basics right, and if we don't have the foundation, how is this going to be actually implemented? I note that you say the bill is constitutionally aligned. Don't you think the freedom of choice is being infringed? When you're looking at the NHI bill, it's actually taking away the right of choice. You are a medical aid scheme yourself. We have hundreds of medical aid schemes out there. People have a choice of which medical aid scheme they want to join. Some medical aid schemes provide better options and services than others, but it's a choice of the citizen of the country to say which medical aid they want to join. With the NHI, obviously, there's limits to everything. So don't you feel that the bill is actually infringing on the rights of choice of residents? My next question, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our healthcare facilities, and the fact that health facilities need to reach certain compliance requirements, we know that under the NHI, there are certain requirements necessary for a healthcare facility to operate. Don't you feel that quite a bit of our healthcare facilities, both clinics and hospitals, will have to shut down or not function under the NHI? And won't this, in fact, negatively impact, service delivery to the masses and those that need it most? Now, I know that you've, highlighted a lot on the governance structure, et cetera. We already know now, with the digital vibe scandal and the corruption and the SIU investigations in all the departments, but relevant now mostly to the health sector. So under the bill's current governance and organizational structure, do you recommend the private sector be included on the board to improve the accountability and legitimacy of the board? Would you recommend parliamentary oversight to mitigate the threat of corruption? Because I note you in your presentation, you've highlighted a lot on the minister's rights on the bill and choice, etc. Do you, as Germs, feel that the bill will stifle the innovation in the healthcare sector? I just have 3 more questions. Do you feel the access to top-up cover will actually assist in covering the extras, like for chronic patients? And do you feel that referral pathways are labor-intensive and could negatively impact timelines and adversely affect the health of patients? With the medical aids right now, there's obviously a system as well where referral letters and so forth is necessary. Now, in normal patients or normal cases, it's fine. But, where cases are urgent, don't you feel that, you know, these timelines will actually adversely impact the health of patients where we may even have fatalities? And my last question, we already know of at least around 104 billion rand in medical negligence claims. Won't this be even worse under the NHI? Thank you, Chair.
Thank you, Honorable Ismail. Honorable members, when we look at our time, we're at 11:15. Our next presentation is to start at 11:30. I think maybe we should curb our number of questions which we raise as we go forward. So we're already going to be late with the next presentation. Please be mindful of it as we continue. Thank you.
Thank you very much, Chairperson. Firstly, let me appreciate and welcome the presentation from James. Chairperson, I've got one question that I want to ask James. But first, let me comment, Chairperson. I think, Chairperson, before I become a member of Parliament, I was a councillor serving in a certain municipality. And you have seen the way James was implementing or handling their members. It was very good, Chairperson. As a result, as councillors, we once said, we wish if also James can accommodate also councillors because of the services that they rendered to their members. James is having a better options and also affordable. That's what we thought and also seen as councillors by then. But also, Chairperson, coming to the presentation, I'm very happy and also glad that James came to us as portfolio committees to present their to come and present to us as portfolio committee members. Coming to the questions that I want to ask Chairperson, it's only one question because they've covered everything. I understand some of us will be not happy when people are saying the truth because currently, indeed, we are not getting a same treatment or a same services. But what government want to do, our government want to make sure that as health sector, we get equal services across the country, all population be treated as same, Chairperson, which is what NHI is trying to push and implement, that all South Africans must be equal, which I also support that, Chairperson. Coming to the question, Chairperson, to James, as a government medical scheme that is reporting to the Minister of Public Service and Administration, are there lessons that you would like to share with the committee on the various accountability lines to the board and the minister and Parliament? Has there been an experience where the minister has placed undue pressure on the scheme? If I can just get that clarity, Chairperson, but I'm happy about the GEMS and also the services that they are providing for their members. Thank you very much, Chairperson.
Me, Honorable Chair.
Okay, Honorable Sukacha.
Thank you very much, Chairperson.
Honorable members, I'm really going to urge you again to go for your questions. We are very far behind with our time. Please, we also need the responses from the presenters. Thank you.
No, Chair. I was after Honorable Wilson. So if you said it's me, it's fine. Let me continue because I was waiting for Honorable Wilson.
Actually, it's actually me, Chair, next.
Yes, I know it's you. I'm after you.
Yes.
I am after Clark.
Sorry, it's Clark and then Wilson and then Sukacha.
Yes, Chair.
Thank you, Chair. Thank you very much. Just a couple of questions. I have been covered by Member Ismail in many retrospects. I'd like to ask the following questions, if I may. So we speak about in the presentation. What I would like to ask is, would you agree that we do have universal health coverage in this country at the moment? The issue with our health care at the moment is that it's not of quality. And would you agree that our health system is not compliant to the 80% of the national standards set by the National Health Department, and that the ideal clinic document, which none of our facilities align or comply with? How will NHI realize these outcomes, and how will NHI prevent the billions of medico-legal claims that we currently face in this country? How will we minimize that, and what role would NHI play in terms of that, just considering that this is a massive budget which is not included into our health budget? Then with regards to your suggestion with the hiring of board members, what recommendations can you provide to improve accountability, legitimacy on the board? Would you not agree that too much power is given to the minister? Considering the recent fraud and corruption that has taken place, and particularly the involvement of the previous Minister of Health, would you not say that Parliament should play a greater role in terms of the appointment of the board and committees, and follow very much the same process as what SABC had done when their board was elected? South Africans has legislation that aims at preventing irregularities in procurement, such as the PFMA, as well as the National Treasury Institution. The problem, however, is in the area of implementation and accountability. We have had state capture, COVID corruption, and civil unrests, and no one has been held accountable. How would you give a recommendation to us today as to how we can prevent this ongoing culture and how we would fix that in terms of the NHI bill? And then how will we adequately prevent corruption, maladministration, theft, and irregular tenders within the management of the NHI fund? Could you please give us your recommendation around this? Thank you.
Thank you, Chairperson. I'll keep mine brief. Thank you for the presentation. Considering the size of GEMS, how do you see the future of GEMS if medical aids will only be used to provide complementary services? Then if people want medical aid just for complementary services, which are not covered by the NHI, surely this is going to have a huge impact on you as a medical aid society, because it actually almost eliminates the need for medical aids. So I'd like to know how you see that this will affect GEMS. On one of your slides, you said when a provider or an establishment is unable to provide a registered service, then people must be transferred to another service provider or another establishment. It's an interesting statement, because already people are unable to get access to medical health or medical services because of the distances and things that they're going to travel. Can you give us a broader picture of exactly how you think this should be done? Because one facility is not going to transfer another person to another facility, first of all. And secondly, there are so few already. People in the rural areas have very, very big challenges as far as getting to clinics and hospitals are concerned. And in terms of what I raised as a point of order, I'm going to go to your almost final slide where you highlighted the blocks, the gray ones, the green ones, and the blue ones. And this is where I was trying to get to when I raised the point of order. What we are looking for is to interrogate your suggestions or alternatives, particularly of those in the blue blocks, those sections of the NHI that you have issues with or you're going to make recommendations on. Can you give us some idea of what some of those blocks are and what those suggestions were? Because that is what we are here to interrogate. I thank you, Chair.
Thank you very much, Honorable Chairperson. Let me also welcome the presentation from Germs. I've just got two questions, Chair, from Germs. Good morning to my colleagues. Chair, the first question is to Germs. Are your members beneficiary of tax credits? As you are aware, Section 49 of the bill states that tax credits will be channeled into the NHI fund. Can you explain to the committee how you are planning for this transition, should it be applicable to your members? Then the second question, Chair, is around, can you share with the committee what your current level of administration costs are at GEMS and how your scheme is planning to reduce these costs and lessons that should be taken into account when the bill is debated and passed? Thank you very much, Chairperson.
Honorable Chair, my first question, Honorable Chair, is the following. I want to get an experience of GEMS on outsourcing of its administration, if they do, that the committee must consider. If they really outsource any administration. Can you share with us, as the committee, what your current level of administration cost at GEMS now, and how your scheme is planning to reduce this cost? And I saw Dr. Stein was showing us they are reducing, but how do they plan to reduce more? And the lesson that should be taken into account when the bill is debated and passed. Thank you very much.
Thank you, Chairperson. Please excuse me for not using my video. My signal is not very good, so I hope you can hear me. Now, I only have one question, and that is the following. My question to James is the following. If you are to become the administrators of the NHI fund, I just want to know, what measures will you put in place to combat corruption within the NHI fund and to prevent looting of the NHI fund? Because like the very first colleague of us said this morning, your organization yourself were involved in a corruption scandal of over 300 million rand. So I just want to know from you, what measures will you put in place to assure and reassure South Africans that the NHI fund will not be looted? We get very nice promises from previous persons, not from your organization, but from government. And we saw what happened with Digital Vibes. So that for me is a great concern, and I think for the rest of South Africa as well. So if you can provide me an answer with that, I will be very glad. Thank you, Chairperson.
Thank you very much, Chairperson. I only have one question for James, and I'm asking this because we've had many presentations, and even some members of this portfolio committee are found to be saying things like, we've got universal healthcare coverage, or that the NHI will bring about universal healthcare coverage, despite the fact that we are all in this particular room or on this particular platform very knowledgeable about what universal healthcare coverage is. And part of those tenets is that people must have access, right, to the healthcare services they need, but not just that. It's also when and where they need them. And in this portfolio committee, especially as members of parliament in the health portfolio committee, we know for a fact that this is not a reality in South Africa. And even when the NHI comes into fruition, it will still not be a reality. We've spoken about this at length in regards to the referral system and stuff like that. In fact, the fact that the National Health Amendment Bill was first rejected in this portfolio committee is also testament to the fact that universal healthcare coverage is something we don't fully grasp, even as members of this portfolio committee. So I want to ask Germs if they think that the NHI will bring about universal healthcare coverage, despite the fact that we are raising issues in regards to people living in township areas, in rural areas, and informal settlements, that they don't have access to healthcare services and healthcare facilities, and the fact that the NHI still won't bring about this particular reality. I'm asking this question because I want to check where the allegiance of Germs lies, because now they are bringing themselves up as a proponent or as a vehicle that will administer the NHIF. So I want to know where exactly their allegiance lies in regards to wanting the NHI to happen, knowing very well that the small details of what universal healthcare coverage is will not be covered through the NHI. And this we can debate whether we like it or not, but the fact that people have to go or wait for a clinic to open in the morning before they go get healthcare services is testament to the fact that there is no universal healthcare coverage. Because if you can't get healthcare when and where you want it, then there is no universal healthcare coverage. So I want to hear from Germs what their position is on the issue of universal healthcare coverage and the NHI. Thank you.
Thank you very much, honorable members, for those questions.
Chairperson?
Yes,
Chair?
honorable.
My humble apology, Chair. You see, my ears are so sensitive, Chair. When somebody mentions something that is not correct, I become irritated. The honorable member who have just spoke about the NHI was rejected, and the NHI was
The National Health Amendment Bill, open your ears and listen. National Health Amendment Bill, you rejected in this portfolio committee. If you're going to come up and speak nonsense, speak nonsense with facts.
NHI.
The National Health Amendment Bill, open your ears. National Health Amendment Bill. There was presented a private member bill by Dr. Susan Tembekwayo.
All three members.
He has the right to speak.
Why can't you listen?
Honorable Chair has the right to speak her mind, please.
Honorable members, I am calling all of you to order. I had read the rules of this meeting this morning to you. It clearly states if you want to speak, please show your hand on the platform. Raise your hand on the platform. If you want to make a point of order, raise your hand on the platform. And I have been very good at noticing those hands when they are raised. So I'm going to remind you of the rules of this meeting, which is an extension of National Parliament. I have now seen two hands being raised and in the following order.
Chair, are you cutting me, Chair? Because I was still on the floor and I was disturbed by these two rude members. I don't know who
please don't call us rude members.
What should I call you?
Never say that. Never.
What should I say?
Your life.
What should I say? Because I was still speaking.
I think you are the one who's rude. You are the one who's very rude.
Behave yourselves. I'm really making a very kind plea for that. So I'm going to put it in the following order. If you want to also speak, Honorable Sukacha, I'm noticing you. I'm going to go with Honorable Tembekwayo, Honorable Chirwa, and Honorable Sukacha in that order.
Thank you, Chairperson. I think this is the time for us to ask the committee that presented some questions. It's not the time for us as members of this committee to exchange, uncanny words and so on. And secondly, to say to you, for your protection, Honorable Chirwa, as a member of this committee, has a right to express herself and to ask her question in whatever way without being interrupted, please. It's a question session, Chairperson. Thank you. And we are not, and I'm asking Honorable Nkolisa to withdraw the word rude. I don't think I'm a doctor who's rude. I'm a doctor, I'm not rude. Thank you.
Honorable Chirwa.
Thank you, Chairperson. I will really just would want to ask for the protection of the chairperson because we are raising questions here to the presenters and we're being interrupted by things that are not even factual. I clearly said the National Health Amendment Bill, and this committee rejected it because they don't want clinics to operate 24 hours and 7 days a week. And you gave us all the necessary excuse of why this particular bill can't pass and go to be debated in Parliament. But when it comes to the even when it was about universal healthcare coverage, and now they want to present the NHI as universal healthcare coverage, but not be taken on that particular fact, and even raising historical facts that have happened in this particular committee. So I'm just asking for the chairperson to have context and to brief the members of the actual eventual facts that have happened in this particular committee, so that we are not abused. I don't like being abused because I can abuse you back. I'm still on the floor. I'm still on the floor. You see, this is exactly what I mean. I'm just as capable. I am just as capable of being rude. I'm just as capable of using harsh words. In fact, I can use the harshest words in this portfolio committee, as you would know, because I'm not scared of any of you here. So don't make the mistake of thinking just because I'm a woman and that I'm young, that you will bully me. It's not going to happen. You're going to listen to me when I speak because I'm a member of this portfolio committee, and you're not going to come up with wrong facts to silence me. It's not going to happen. You're going to listen and stomach all the things that I'm telling you because they are factual and they are scientific. It's not an opinion that is based on political allegiance. There's no universal healthcare in South Africa. The NHI will not bring it because people will still go to clinics that don't open for 24 hours. That is a fact. So I must not be bullied because I will bully you back.
You are protected, Honorable Chirwa. Honorable Sukacha next.
Chair. First of all, let's clarify things here. I never interrupted anybody. The Honorable Chirwa was finished speaking, so I never interrupted her. And secondly, this is a public platform and we're dealing with the National Health Insurance Bill. The Honorable Chirwa did not explain what bill she's talking about. She just said the bill was rejected. And my ears become sensitive.
Point of order, Chairperson. Point of order.
I have not. I've given her time to speak. I've given her time to speak.
Point of order, Chairperson. It's a point of order. It's a point of order. It's a point of order, Chairperson.
Honorable Chirwa, I'm going to answer what you had said. I heard you very clearly the first time you spoke. So give me a chance.
But no, Chairperson, you can't allow members to lie in this portfolio. It's always lying. Like, why do people have to lie? I didn't say just a bill. Why would I say just a bill? Because there was a private member bill by Dr. Susan Tembewayo, by the EFF. Why would I not mention our bill?
Let me then say what I heard you say. I did hear you say what was it, the private members amendment bill? What it was a private members bill? It's called the health amendment bill.
I said the National Health Amendment Bill. The National Health Amendment Bill. I mentioned it the first time. I mentioned it when I was interrupted. I mentioned it even in my comments now.
Honorable Chirwa, give me a moment to manage the meeting. I have just said that I agree with you as to what you had said. I now need to bring that to the attention of Honorable Sukacha. So allow me to do that, please. Honorable Sukacha, Honorable Chirwa did say what she said she had said. So please do note that. You could maybe not have heard it correctly, but she is very much correct as to what she had said. Please continue, Honorable Sukacha.
No, Chairperson, as a disciplined member, I will accept your ruling. And I still want to emphasize the word rudeness refers to somebody when somebody speaks and you interject. You see, I was quiet when the Honorable Shira was speaking because I'm a disciplined member. I listen at it is you as you are chairing the meeting. So if I heard the Honorable Member wrongly, then that is my humble apology. But the rudeness means when somebody speaks, you keep on speaking. That's rudeness. Thank you very much, Chairperson.
Take your L, man. Take your L. You must open your ears next time. You are working, you are busy. Open your ears.
My hand is up as well.
Honorable Sharwa, I thought we were just going forward. Honorable Budiai, do you want to say something? You next.
Yes, my good chairperson. One key issues we are about what has been presented by this organization called Germs. And we're here about NHI bill, not any other bill. Can you allow us, chairperson, to focus on that? Please.
Thank you, Honorable Budiai. Let me then also raise a few points I wanted to raise with the presenters, and I would have to allow you extra time. I had noticed that the next group of presenters are on our platform, and I really apologize to you that we are running a bit late now. I'm going to be a bit stricter about time management as we go forward, and I'm saying that very clearly to you, honorable members. Please cut those number of questions which you have, and also speaking around the matter, not going straight for your concerns. So my concerns with you, the presenters, is that your membership of Germs are government employees. It's established in terms of the Public Service Coordinating Bargaining Council. The Germs has been established and negotiated at that platform. How does Germs envision the transition of its members from Germs to the NHI? And is there a process or education that you are undertaking with your members and beneficiaries of what should be expected when the NHI is implemented? And then just a final one, your experience on outsourcing of your administration that the committee must consider. As stated in the section on the purpose of the Act, NHI will be established as a single purchaser and a single payer. So your comments on all of these questions are welcome. I would have to say that I would have to restrict you to and I'm just trying to look at the time, to 19 minutes, 18 minutes now. Anything that you had not completed, you're very welcome to write to us, because we are going to be 13 minutes late, and I hope Professor Parry had heard my apology for that as I am talking. Please continue with your responses.
Thank you, Chairperson, Dr. Jacobs. Chair, if the rules allow, as you have stated, anything that the honorable members may have asked that I will not address, we will duly, if those questions are submitted in writing, we will answer them. Chair, the first, I believe, at the beginning was Honorable Clark, who stated...
Sorry, Dr. You actually have misunderstood me, Dr. Malawi. I'm saying any questions which are not able to answer today, you put in writing. We will not be writing to you. Thank you.
Okay, thank you, Chair. So the first honorable member who asked the question, I think it was Honorable Clark. Can I just confirm that, because the order at the time, can I just confirm that, Chair?
Yes, let me have a look for you. The first member asked a question.
Dr. Tembagwai was the first.
Oh, yes. Oh, okay, thanks. Thanks, Chair. Yes, Honorable Tembagwai, you indicated and stated that it seems that Germs has been promised to run the NHI. I humbly submit that that is not the case, so that's not true. On the issue of governance issues that are alleged to have rocked Germs, including fraud, tender, manipulation, and all of that. And that was, I would imagine, as a result of that publication that circulated, and I think it was News 24. Chair, we have dealt with that both addressing the very same parliamentary committee early last year and explained what happened in relation to those allegations, which are said to be amounting to 300 billion. The amount is also wrong. Basically, that has been dealt with by the board. The officers of the scheme who were alleged to have involved themselves in those activities are no more part of the scheme. They either left the scheme via resignation or were dismissed through a proper process within the scheme. And as a result of that, the findings that the board has, we are pursuing both criminal and civil litigation to recover what is recoverable. So, and there is mention of 10 forensic reports. I'm not aware of 10 forensic reports. That's there was a forensic, there was an inspection within Germs, and then as a result of those allegations, the board did actually say this must be investigation, but it is not 10 forensic report. Thank you. And I think the next questions were Honorable Ishmael. I did note that most of the questions that were asked by Honorable Ishmael were actually leading in nature. One of the things was, the question was do we believe, in fact, it was you, as in me, that the bill provides for the attainment of universal healthcare? I think I agree. It is actually a step towards attaining universal healthcare coverage, which the country is committed to. How will this be achieved with a smaller tax base? Well, the management of resources, particular financial resources, it's always under circumstances where there's little to do what you want to do. So there's allocation of budgets that are done on the basis of work that is done, and it is managed. So healthcare resources are managed on that basis by the fiscus, and it's usually treasury. Do I feel that the NDOH will be responsible for infrastructure? The duties of government, whether it be at national, whether it be at provincial level, or whether it be at local level, are stipulated in in the structures that governance has. What are the responsibilities of the various tiers of government? So at the end of the day, I think the government will always identify priorities and make budget according to the needs of the society at large. And I believe that is the approach. Is the freedom of choice being impinged by the bill? I think actually what the bill seeks to do is to create access to healthcare that is appropriate, that is clinically appropriate. So if that is the intent, I do not believe that the freedom of choice is being impinged upon. We do know that there are factors, and some of them have been stated, that hinder access to healthcare. But in the planning, I suppose this will always have to be dealt with. You indicated that there are hundreds of medical schemes. It's actually, there are just under 60 medical schemes that are registered with the Council for Medical Scheme. And yes, the importance of compliance cannot be understated. And I know the healthcare providers are fully aware of the need for accreditation, and they are doing what they are supposed to do in terms of attending training courses to enable themselves to apply for accreditation when this becomes in force. So I think the compliance requirement, all the players are aware, and we all know that we have to adhere to the attendant acts, laws, and regulations. Do I recommend, or does Germs, maybe it should have been, does Germs recommend that private sector should be involved in the board of the National Health Insurance? The way I understand what is in the bill and I suppose that's our understanding in general, is that it is not categories that will be appointed to the board. It is individuals who are deemed fit and proper, and they have the necessary skills to advance the objectives of the National Health Insurance Fund. Those are the people who will be considered for appointment into the board, and the criteria is set out there in the board in the bill to the extent at the level it is represented in the bill. And then the issue, I think the issue of corruption I've dealt with. There's about 104 billion medical negligence bill. It is something that is of public discourse, and I know that it is something that is being dealt with. In terms of negligence, it is not like national health insurance within its responsibilities. Then when you look at these negligence things, the Healthcare Professional Council is the one that has oversight on what the healthcare providers, how they discharge the practice of the healthcare delivery. So these are things that fall within the ambit of the Healthcare Healthcare Professional Council of South Africa, HPCSA. I think from Honorable Gela, thank you very much for your encouraging comments. Your question is the need to delineate the accountability lines between the minister, the board, and obviously other officers of the scheme. I think it is provided for in terms of the governance structures. But you asked, what are the lessons that we have learned in our reporting responsibilities? I don't know if any pressure. I don't know if any pressure that has been exerted on us. I'm not aware. So, Chair, that was Honorable. And then Honorable Clerk, not compliant with over 80% of the standards that are determined by the, well, I suppose whenever you are faced with something that you implement, you improve as you go along. And I think those health establishments that did not meet the minimum standards will do something that when the next round of assessment happens, well, we would hope that they will have improved from where we are. So the establishment of the National Standards Authority is a very important one to assist in for us to be able, as the healthcare establishment, to able to do a check on themselves. There was this reference again to the legal, medical legal. I think I've addressed that one. Should there be Parliament involvement in the appointment of the board? I think this democratic legislative process, it actually provides for recommendations to come from all angles of society to ultimately influence how the bill will ultimately run. So I think the opportunity would be within the honorable members. I don't know whether there's prohibition for Parliament oversight committees to make inputs, but things like that I think can be discussed at that level. So what are the recommendations to the Committee on Governance? And I think the structure is there. There's always I think it's in the latest, the King 5, the King 4, in the King Principles, we talk about when you determine the size or the structure of a governing body, you must always take into consideration the size, the complexity of that organization, and then and the role that you want them to play as a governance oversight body. So we should just follow those principles that guide. And I think in the proposals that are there in the bill, it is clear what the size should be and all of that. Honorable Wilson then asked what will be the impact of NHI on GEMS considering the complementary role. There'll always be a role. Remember, firstly, the implementation of NHI is not an event. It is a process that could take any number of years. I know that we are desirous of reaching the end point as soon as possible. However, the reality is that things like this, when you implement them, you do in an incremental manner. What that then means is that, like it happened in '94, and I alluded to this, that President Mandela on health, the first thing he addressed was, he then said there will be free access to health for children and for women. So that's the introduction of a move towards universal health care. So everything will happen in an incremental manner. The fact that we have a pandemic coming from nowhere may have actually affected the rate at which we'll implement NHI. These are the realities. So it will be done in an incremental manner, and as services shift to NHI, those services will no more be available in medical schemes environment in terms of benefit that will be stipulated from a regulatory point of view. And I think that's how it will happen. And then what about the availability of services, for instance, in the rural area? I just briefly want to share what I have learned as I did various training on healthcare funding. One of the case studies was for Haiti after the devastating earthquake they had. And one of the things that they had to deal with was access to healthcare, particularly for treatment of those patients who had TB in the rural areas. Their clinics were very far, and these people could not go to the clinics. And what they introduced was a buddy taxi system where if you own a donkey cart, you then collect the person who needs to go and take treatment for DOTS. DOTS is directly observed treatment, as you know. So, and that had a huge impact on the success on Haiti dealing with the issue of TB. After that, I think it was a 2010 earthquake. So essentially, we have to be innovative in ensuring that there is access to healthcare. Honorable Sokacha, are there GEMS members who are beneficiaries of the tax credits? Everybody, I think, who basically uses any healthcare services in the country would be a beneficiary of the tax credits. And tax credits are very complex, and I'm saying this from my point of view as a layman in issues of tax credits. Basically, that there is a contribution for us who are taxpayers, and then the tax credits are given according in terms of your tax return. And in essence, there may well be beneficiaries of GEMS who are beneficiaries of the tax credits. That is the best answer I can give to you, Honorable Sokacha. What are the levels of administration with GEMS? In the presentation, I stated that the costs are 4.5% of contribution income as at the end of 2021. The industry average is just from the 2020 Council for Medical Schemes report is 8.6. So we are fairly below what is allowed is that 10% of contribution income can be used towards non-healthcare costs. And non-healthcare costs is both service providers and corporate services, which include personnel, infrastructure. We spent generally around 4.5%, and we have been low since inception. We have always been at about 7% and below, whereas at the beginning, around when GEMS started, the non-healthcare costs were around 18%. We have always been around half of what the industry standard is. And just briefly, in terms of the admin costs that I've now indicated, the GEMS is basically looking at the structure of how GEMS will operate in the future, including how services will be sourced, whether in-sourced or outsourced or cost-sourced. All of this are receiving attention. And then Honorable Van Standen, how will GEMS protect NHI fund from corruption? I think I have stated in one, and that's when I was interrupted. There was the slide that was basically saying, in terms of governance, the GEMS board have made it a point that they equip themselves with all the skills, including belonging to societies like the IODSA, and ensure that it puts in place checks and balances to ensure that corruption does not occur. We have independent committees like the audit committee. We have risk and social and ethics committees that were established by the board, which, by the way, the audit committee is a minimum requirement in terms of law. The other committees that exist, like the risk, social and ethics committees, is not a minimum requirement of the Medical Schemes Act. So these were put in place by the board to ensure that we deal with issues that may lay us astray. So Honorable Naledi is basically asserting that universal healthcare will not be reached as a result of NHI. And I'm basically, in terms of the GEMS approach, has always been, we monitor the policy evolution in terms of healthcare funding. We align our benefits. We promote access as best as we can in terms of entering into arrangements with the healthcare providers. Hence, we won that award on the creating access to healthcare. We do everything within what is practically possible to align ourselves and products of GEMS towards reaching universal healthcare coverage. And by the way, we also know that universal healthcare coverage is utopia. That's the best that we want to reach as a country. And if we don't work towards it, we will not get halfway towards it. But if we work towards it, as we're saying we are doing it, with the support that we are saying we have for NHI, we will at least achieve some measure of universal healthcare. I think the points, Chair, before your last points from the other members were really dealing with issues of the House. How do we envision GEMS, that's the last question, Chair. How do you envision GEMS transitioning from just being a purely public sector scheme to where maybe all other people can be admitted? I think, Chair, in terms of the mandate, and yes, you said we are actually established in terms of a decision of cabinet and the employees. However, we run in terms of the Medical Schemes Act, and there's a lot of strategic planning that the scheme does. We look at scenarios of what can happen, and then we basically, not as people say, have said earlier, position ourselves to run the NHI. GEMS is modeled to be a blueprint of what the policy changes will become. So be ready if you need to also bid or whatever process will be followed by government to contribute towards the running of NHI. By the way, there is no one entity that can run the NHI. There's the current service providers and experts and advisors who are in the healthcare funding industry will be even small to can run. We're running a industry of about 9 to 10 million. The country has got 60 million people. You're going to need more people. And I think that's an important point that needs to be considered as well, to ensure that the skills that are currently available are used. In our experience on outsourcing, we have built the scheme on that. We have to monitor it very well. We have become wiser in monitoring outsourced contracts. However, the future GEMS will be a mixture of both insourcing and outsourcing when necessary, but largely in-source services. Thank you, Chair.
Thank you very much for answering those questions. There's one question which you didn't touch on, but I think I will just quickly touch on the issue of whether South Africa is currently experiencing universal health coverage. Not according to the definition that was used. You want to quickly speak about it? You have 1 minute.
Sure, I think there are just elements of it, as I indicated, that our revered leader, Rolihlahla Nelson Mandela, when he became president in Nigeria, for the first thing he did was introduce healthcare services for the under fives and free healthcare services for the women. And that was the start. So there's an element of universal healthcare. It started there. We need to just then progress this incrementally into the future. So there are elements of universal healthcare in the healthcare system at the moment, Chair. Thank you.
All right, except that the definition says, as has been said by Honorable Chirwa, it's services, health services, when they are needed, but another addition without financial hardship. So no, yes, we don't have universal health coverage in our country at the moment. It is the aspiration of the Nhi Bill to bring people universal health coverage, and I think we need to put that very categorically, and I think maybe that's my duty according to the definition of UNHC. Thank you very much. You have 30 seconds to say some closing remarks, and we will go over to the SAMRC.
Maybe Chairperson Dr. Millie, if I can please request you do.
Thank you so much, Dr. Stan. Thank you so much to the Portfolio Committee, particularly Dr. Jacobs, for allowing us to give this presentation. This is a very contentious issue, but we all need the best for our citizens so that the status quo cannot remain the way it is at the moment, unfortunately. We need to be able to assist as a scheme to achieve what the NHI stands for. Thank you so much for giving us the chance to come and present. And we would like to thank everybody else. And thank you so much.
Thank you. You're very welcome. Our next presenters will be from the SAMRC. It is a particular unit called the Alcohol, Tobacco and Drug Research Unit, led by Professor Charles Parry and his other members of the team are Professor Melvin Freeman and Ms. Jane Simmons. You are very welcome. I'm going to extend the same time to you as all others, which will be 1.5 hours, including the discussions. And please be mindful, honorable members, there will not therefore be a lunchtime today because we are really running far behind with our schedule. Honorable Munyai.
Honorable Chair, I want to establish whether the South African, their organization has returned twice to request for presentation. Because so far as I know, there was only one request to present from South African Medical Research Council. There was not 2 requests. Because remember in the beginning, all the organizations that requested to come and present, there was 1 organization. There was not 2. Why are you allowing 2 presentations from the 1 organization?
Honorable Munyai, let me answer that. There were 2 requests. We've agreed to 2 requests because these are different units within the same entity. And remember that this is our South African Medical Research Council. It's a very big unit and a big organization. It is actually what I said in the beginning, and there was reason for me saying it, that it was allowed because they will speak specifically about issues which were not spoken about before, and it's not the same presentation that they had done before. So please indulge me with this. It is something that I did interrogate yesterday, and I did apply my mind to it, and I'm going to allow it in the context of this being a brand new presentation and also a different unit within the SAMRC. Please continue, Professor Parry.
Thank you, Chair and other members of the committee. We welcome the opportunity to speak to this Committee of Parliament today on this important issue about the bill. And the presentation, as I said, comes from the unit I lead. And the input that will be given today was based on work undertaken by Professor Melvin Freeman, Ms. Jane Simmons, and myself, who are all here today. Our main argument is that including a strong focus on health promotion is a prerequisite to the success of implementing NHI in South Africa. Professor Melvin Freeman will give the presentation, and all three of us will be available for questions afterwards. So I'd like to hand over to him now. Thank you.
Morning, everybody, and thank you for this opportunity. I'm sure that you will find that this is of different content to what the MRC has already presented to you. If I can just share my screen, please.
Yes, thank you.
Right. So Professor Parry has said that we are going to be making the point that keeping people healthy is a prerequisite to the success of the NHI. And I have got quite a lot of slides, but that is the theme that is going to be running right through this. And we will argue that the bill concentrates a lot on the services and the supply of services side of things, but not on the demand for services. In other words, the numbers of people that need care. And our main argument is that if the NHI is going to be a success, then it's got to keep the numbers of people who get sick to a minimum. So that's really the theme of what we are going to talk about. And we're going to now run through why we say this is the case. Okay, so the outline of our presentation is why the NHI must have a clear focus on health promotion and prevention of illness. We're going to be looking at the crisis of non-communicable diseases and the non-communicable disease risk factors. And I'll say why we're focusing quite a lot on them rather than the communicable diseases, and also the relation between non-communicable diseases and COVID deaths. Then I'm going to be looking at some of the economic benefits of interventions for health services and the economy by reducing the demand side. We'll look at what we mean by a health in all policies approach, and we'll then look at what the NHI currently says about health promotion. Sorry, was there somebody? Can I carry on?
Please carry on. Can you please mute your devices, all of those on the platform? Thank you.
Okay, and then we're going to give specific proposals for revised legislation, and we will look at, very briefly, at Thailand and their health promotion foundation that was established as part of NHI and how that has made NHI possible within that country. And lastly, just briefly, the conclusion. So that is really what I'm talking about. So we argue that NHI will, to a very large extent, flourish or flounder on whether the numbers of people that will require healthcare can be kept to numbers where it's possible to provide good quality care to all that needs it. It's a simple fact that the more people that require care, and particularly care for chronic conditions, the more strain there's going to be on the NHI fund. And therefore, keeping members of people needing healthcare down is central to the survival of the fund and the sustainability of the fund. And what is very worrying is that current health trends show increases in a range of critical diseases and their risk factors. And unless that's reversed, or at least substantially reduced, the NHI is not going to have a real fighting chance. So we are, in essence, saying we support the NHI, but if the numbers of sick people grows in the way it's growing at the moment, I don't know that the NHI has actually built in terms of funding for such services into the NHI fund, or otherwise the amount that is going to have to be paid in is going to have to get more and more as the years get on, because more and more people are going to be getting sick and are going to be needing the services. The good news, I suppose, is this can be prevented, and it is possible to prevent illness if we use evidence-based and cost-effective interventions. But it's a complex process. Reducing the numbers requires approaches that actively promote the health and well-being of citizens through a range of different interventions, and particularly multi-sectoral interventions, because health is not just a health problem. It's a problem that many departments need to get involved with in order for us to really bring down the illness numbers and take up the good health numbers. So to do this, we need to invest in health promotion as a vital element of NHI. And the question may arise, why should this be part of NHI? Shouldn't it be the role of the health department? Well, we're going to argue it is a critical component of NHI. This is a neglected area, so I'm going to put quite a lot of emphasis here. And the overall, overwhelming and broad consensus, including from the UN General Assembly, and I'm not talking about the Assembly of the World Health Organization, I'm talking about the UN General Assembly, is that to comprehensively address mortality and morbidity, we need health in all policies, whole of government, and a whole of society approach. Without that, we fail. So let's just look at this crisis that I'm talking about. From an in-depth analysis of health and risk factors in South Africa conducted within the South African Medical Research Council and elsewhere, there's an alarming rise in the incidence and prevalence of these NCDs and their risk factors. And to get back to my theme, if South Africa is serious about wanting to avert a major mortality crisis, we either can urgently and dramatically reverse current trends by improving the health of the population, or we will have to extensively expand our health services, even beyond population growth over the next decades. And I wonder whether NHI is prepared for that. I think not. So I want to just give a couple of examples of some of the trends which is worrying. So if we look at mortality from NCDs, the probability of dying prematurely, that's between the ages of 30 and 70, due to certain NCDs, is 34% for males and 24% for females, 29% for both sexes. Is it not becoming already clear that if we could reduce those numbers, how much better quality of care we could provide to those people who do get sick? In terms of the SDGs, we got to reduce this target by 1/3 by 2030. Don't know that we're ever going to get there. But just to show you briefly, and we don't have the updated statistics beyond 2016, but you can see that for a long period of time, especially when HIV was at its peak, the deaths due to communicable diseases were higher than those due to non-communicable diseases. And perhaps now too with COVID, that might be the case too. But you can see these trends in which non-communicable diseases are getting higher and higher, proportionate to the numbers of people from dying from communicable diseases. And what's so important here is that so many of these deaths are preventable. But they won't be prevented unless we put in the necessary measures. Let's just look at hypertension as an example. In both men and women, we just see this constant rise in hypertension. From the 1998 South African Demographic and Health Survey through the 2008 one, through to the 2016 one, one just sees this rising and rising and rising, and we've got no reason to believe that this is not going to be rising further and further and further. Worrying, extremely worrying. Many of these are preventable. Without preventing, what's going to happen to NHI and the fund? Let's look at the issue of obesity. Again, even in young people between the ages of 15 and 24, high levels of overweight and obesity in the country. And I think many of you have seen these slides before, but the fact is that it's getting worse, not better. And I'll show you just now what the implications are of obesity for healthcare expenses. So why focus on these risk factors? Well, we don't know the exact extent to which modifiable risk factors can prevent NCDs in South Africa because it hasn't been calculated. But in the WHO region of the Americas, it's estimated that 80% of all heart disease, stroke, and type 2 diabetes, and over 40% of cancer is preventable through multisectoral action. So if we do the right things, we can bring these numbers down. And if we bring the numbers down, what a fabulous NHI we're going to have. Also in relation to COVID, we also know of the comorbidity between COVID and NCDs. And again, if we would have had less people with NCDs or underlying health conditions related to NCDs, then the current mortality in South Africa of people dying from COVID would have been so much less. So let's reduce our NCDs, which we know how to do. Then if we have another epidemic like COVID, our deaths will be so much less. So from every point of view, fewer people with NCDs is good for the country. And achieving it is possible with sufficient commitment and evidence-based interventions. But now, importantly, while health behaviors and choices are practiced by individuals, they're usually driven by forces that lie outside of their direct control. So it's not just a matter of telling people what they should be doing. And in that way, we will bring these numbers down. It's much more complicated than that. You know, we often say to people, eat 5 fruit and vegetables every day. Well, if you don't have access to 5 fruit and vegetables because you can't afford it, then that's not going to help you at all. And we can't blame that person. We got to blame the system, which doesn't allow people to do that. So behavior change involves a complex set of interventions that go beyond the individual and involve cultural, social, and economic factors, including the commercial determinants of ill health. So some people are making profits out of ill health, and we need to look at that and tackle that. And we need to look at those, what we call proximal, as well as the more distal causes of ill health. Now, one of the important areas, which I'm not going to go into unless people ask later, and perhaps Jane Simmons can do this more, but there is something called social behavior change communication, which tries to take the whole messaging of what we should be saying and how we should change things to a different kind of level so that we don't just look at giving individual messages to people and expecting change, but putting that within a context of a broader framework and concentric circles of influences on people's behavior. But let me not get into detail around that. Then let's look at the economic benefits of doing this. So I'm saying that the economic benefits that go beyond the numbers of people who are going to get sick and who will need healthcare from NHI. So the WHO's global business case for NCDs show that if low and middle income countries put in place the most cost-effective interventions, most of which are preventive and promotive, by 2030, they could see a return of about 100 Rand per person for every Rand we actually invested in these programs. So while accurate costing of diseases and the longer term implications of not preventing diseases, including the proportion of costs from preventable diseases, is unknown. It's estimated that for diabetes alone, in 2018, the public sector costs was approximately 2.7 billion and would be 21.8 billion if both diagnosed and undiagnosed patients were considered. Again, people can ask me for the details and I'm happy to go into this, but I'm rushing through. And essentially what I'm saying is invest and you'll get savings. Unhealthy people place an unnecessary burden on healthcare services. Now, I said when I was showing the obesity slide that I would show you what the economic implications are on this. Well, moderate obesity is associated with an 11% increase in healthcare costs and severe obesity with a 23% increase. In other words, if you have severe obesity, you're going to cost the healthcare system about 23% more than somebody who is not obese. So should we not be reducing obesity rather than paying the extra healthcare costs? Isn't that a logical thing for the NHI? In real terms, it is estimated that by 2030, costs of all type 2 diabetes will increase to 35 billion. Such increases are simply not sustainable for the NHI, especially as diabetes is only one of several of these NCDs that are growing. So it's been estimated that the economic cost due to productivity losses arising from absenteeism, lack of presenteeism, and early retirement due to ill health, largely from NCDs, equated to a total of 6.7% of GDP in 2015 and is expected to increase to 7% of GDP by 2030. We can't afford it. Okay, so there are basically 5 major risk factors from an NCD perspective that we should be focusing on. One is diet, one is tobacco use, one is alcohol use, one is physical inactivity, and the last is air pollution. For each of these, we know a lot about how to change, but we lack commitment to do it and we lack resources to do it. Okay, now to get to the NHI bill. So the NHI bill, as well as the Memorandum of Objectives and the Department of Health pamphlet explaining NHI, all mention the importance of prevention and promotion. But this is not translated into concrete proposals of what will be done within the NHI to achieve this. If we look at section 37.1 of the bill, it refers to health promotion being managed as part of the contracting unit that manages primary healthcare services. And section 57.4.1 considers the need for purchasing healthcare service benefits, and it says including health promotion. But we argue very strongly that the conceptualization of prevention and promotion in this way is extremely narrow and may merely translate into education and information programs, which are not evidence-based and that most health promotion experts regard as a waste of time and resources. We're also very worried that if somebody is commissioning services as well as preventive services and they don't have enough money, well, the first to go is going to be the prevention and promotion. And that's the experience of the past, and that's what's going to happen now as well. So there are 2 issues. The one is they're going to commission the wrong kinds of services that are not evidence-based, and they're not going to do it at all. Okay, so when we're talking about health promotion within the fund, we need something that's multi-sectoral, evidence-based, and adequately resourced in order to make a real difference. Now, it is quite interesting that in earlier NHI documentation, they spoke about one of the committees that should be set up as part of NHI was a National Health Commission. In 2017, the Department of Health circulated the document, NHI Implementation, Institutions, Bodies, and Commissions that must be established. And it was sent out for public comment. And in this document, it stated that promoting health and preventing illness is central to the NHI, as well as to social and economic growth and development in South Africa. It stated further that a structure would be set up to deal with determinants of health, including its social determinants, as part of NHI. It proposed that a National Health Commission will be established with a primary objective and purpose being to address the social determinants of health through a multi-sectoral and developmental approach involving key government departments and non-state actors. And finally, it said that the Commission would coordinate key sectors in implementing health in all policy and an inclusive approach to dealing with NCDs, but it's health issues, including mental health. So our question is, what happened to the structure? In later iterations of what the NHI would be composed of and what it would do, particularly the bill, this proposal, which could be extremely important, I hope I've convinced you, has completely disappeared. If not changed, this omission may well prove the Achilles heel of the NHI. I've got a bit of a time constraint, I think, although maybe it is very important and particularly important for the South African Medical Research Council that we need the proper research and evidence for the interventions that we are going to introduce. And to ensure that interventions are evidence-based and do not merely waste resources, we need more research on health promotion. And this needs to be fed into the NHI structures so that resources are channeled into interventions that reduce healthcare costs and the fund. It should be paid for from resources committed by the NHI fund to the National Health Commission or to a health promotion foundation or similar, we can call it whatever we want. And the SAMRC would be more than keen to play a role in conducting research in collaboration with the NHI structures. So what are our specific proposals that should go into the NHI Act? Firstly, we say that a percentage of the NHI fund, a minimum of 2%, must be earmarked in the legislation for health promotion from the fund. And I'll show you what other countries spend on NHI, on health promotion. 2% would translate into around about 8 billion rand, which would be a fair allocation for the amount of savings it would bring. And in my view, for saving the NHI from collapsing, given the numbers who are going to need to use it. So a multi-sectoral structure, such as the National Health Commission or a National Health Promotion Foundation, must be established as part of the NHI and funded by the NHI fund to promote health and ensure that fewer people require curative health. This is what we're asking for. This is the change that we're asking for. Just to give you some idea, this is OECD countries in 2019, just to show you how much they spend on overall prevention and promotion services. It does go as low as a little over 1%, but it goes as high as over 6% that people spend on it. I don't know South Africa, but it would be certainly a lot less than 1% currently. But you can see that the majority of countries spend around about 3%. So our request for 2%, we think is very reasonable. So some of the research questions that we need to look at is what health promotion works globally and can this be used in South Africa? If not, why not? And what would work instead? What are the best buys for getting our bang for our buck? What health innovation could be introduced to South Africa that have not been tried elsewhere? We need to have demonstration projects with thorough evaluation of what works and why. And we need health promotion initiatives that are introduced that are thoroughly evaluated for both health and cost benefits. I just want to lastly give you some idea, as I said, of the Thai experience. So when they started their NHI, they simultaneously established what they called Thai Health to focus on promotion and prevention issues. And they argue strongly in a number of papers that this has contributed significantly to the success of their NHI. And what Thai Health does is focus on the major NCD risk factors, on tobacco, on alcohol, physical activity, and diet. But where they pick up that things like poverty, for example, is considered to be impeding people's ability to eat healthy foods, the structure allows them to involve ministries that can assist. For example, the ministries of Treasury, Agriculture, Trade and Industry, and so on. So it is a truly multi-sectoral approach to dealing with health issues. So for a population of around 69 million, the amount allocated to the foundation is around 1.8 billion rand, and this translates to per capita expenditure of around 25 rand per person per annum. And I'm not going to go into these details because of time, but you can see from your slides that they have managed to reduce a lot of the risk factors and thereby increase health through the work that they've done. So we think to promote health, prevent illness, NHI will work. We have published 2 articles, or an editorial and an article in the South African Medical Journal. It's on health promotion, how government can ensure that the NHI fund has a fighting chance, and failing to respond to health promotion imperatives could scupper or hamper NHI efforts. So if anybody's interested in reading those articles, we can either give them to you or they are accessible through the South African Medical Journal. So what's our conclusion? NHI legislation, South Africa can either plan for care for more and more ill people over the next few years as the numbers needing care increases beyond population growth, and in all likelihood fail to be able to provide the resources needed, or it can put significant focus and resources into promotion of health and the prevention of illness, and thereby make the NHI sustainable in the longer term. So in particular, our proposal to the NHI legislation is that it must establish a National Health Commission or a Health Promotion Foundation as part of its structures, as was recommended in an earlier iteration, and it must legislate that at least 2% of the NHI fund must be dedicated to health promotion and prevention activities. This will give the NHI a real fighting chance of survival. Thank you very much.
Thank you very much for the presentation. Honorable members, you have seen the presentation, you've heard the presentation. I have 4 members so far who want to raise questions with you. It's Honorables Wilson, Tempekwayo, Gela, and Supacha. Any other members who want to?
Honorable Munyai.
Honorable Munyai, next. Honorable Howard, I see on the platform, yes. Next.
I'm covered, Chair, thank you.
All right. Honorable members in that order, thank you.
Thank you very much, Chair, and thank you to the MRC for a thought-provoking presentation. It is much appreciated. I have a couple of questions. And I hear exactly where you're going, and I couldn't agree with you more. The problem we currently have is that access to facilities, number one, is a huge problem for the majority of the population, particularly those in rural areas. When they get there, there is lack of resources, there's lack of medications, lack of appropriate care. So with regards to your non-communicable diseases, this is already a huge, huge challenge for a vast amount of people in this country, considering the amount of people who have AIDS, who have TB, and I know they're communicable. diabetes, all of the kind of things that you were talking about. So this is already a huge problem. So without access, what do we need to do should we not be putting more emphasis on appropriate resources, access, staffing, having those in place so that we can roll this out appropriately, should they not be there first? And I want to deal with addiction, and I've had this discussion with the MRC before. There are only beds in this country for less than 1% of people who are suffering from addictions, whether they be drug or alcohol abuse. This creates a huge problem, because until such time as we can treat them and treat them appropriately, we are going to battle, they are going to battle, and we are going to pay for their ill health. And most of these people cannot get access to a lot of the drug rehabilitation centers without a medical aid. This is a huge problem, and should we not be addressing this as part of the issue as well? And I want to deal, and I'm going to use Limpopo as a specific example. So in the newest report from the Department of Health in Limpopo, there are 1,575 medico claims to the tune of 14 billion rand. Now, 518 of these were cerebral palsy as a result of problems at birth, bad deliveries, no resources, not being able to do Caesars when Caesars should have been done, lack of oxygen, incubators, all of those kind of things. 499 were obstetrics and gynae, 168 orthopedic, 169 surgical, and they registered 221 as other. Now, this has a huge impact on budgets. Apart from the fact that if even just half of these cases are won, we need to find 7 billion rand. But the impact that these kind of things have on the medical system going forward is huge, because these people are now going to require, particularly your cerebral palsy children and people who have got now serious deformities, or who are not be able to function or be mobile in the normal sense of the word. That is having a huge impact. It's going to have a huge impact on the budget, and exactly what you were saying. These kind of things should be prevented. Okay, now we sit with a situation where those 1,575 people potentially need medical care for the rest of their lives in one way or another. This is not taken into account. So I couldn't agree with you more that we should be preventing and promoting good health. But one of the things we have to prevent is the lack of resources, specialists, and availability of proper resources in order to prevent these kind of medical claims. I would like your comment on the fact that the NHI, which is a funding model, proposes that the government or the NHI becomes the single purchaser of all things, of all medicines, resources, etc. Does that not pose a problem for you? And particularly in what you do as a medical research council, a lot of the comments that we are getting is that this is going to halt innovation. If you've got a single purchaser who is going to decide who gets what and why, will it not stop people trying to be innovative, to come up with better solutions in the medical industry, better alternatives, even homeopathic as an example, because they are not going to have any success in delivering great new ideas into the NHI fund. You talk about population, and in the NHI a lot, we talk about the South African population, which is just over 57 million. But the biggest problem we have is that apart from 57 million people who already battle to get access to healthcare, we have a good possibly 10, 15 million more foreign nationals in this country. Whether they're here legally or not is not the issue. The fact is that we are bound to give them health services. What kind of impact, and if we can't give them that service, we are not going to be able to beat this battle. And then a simple question. With the NHI, with its proposals, in its current form, would you say that the NHI is sustainable? Given the current levels of poverty, the joblessness, the fact that this is going to involve taxes, and the fact that because of poverty levels and joblessness, there is no way people can get access to proper nutrition. We are going to see an increase in diabetes. We are seeing already increases in all sorts of areas, malnutrition, stunting of children, in all of these areas as a result of that. And this is going to get worse. It's not going to get better. And how would you respond to that? I thank you, Chair.
Thank you, Chairperson. I've got two questions to the committee, and thanks, committee, for your presentation. I just want to find out when the presenter was talking about the Thailand and in addressing mortality issues, he mentioned this approach of health in all policies, but I would like to have examples of how whole of government and specifically whole of society can be applied within South African context. Can he be able to give us concrete examples of how those specific approaches can be applied within South Africa, and to ask whether those approaches fit into the current proposed NHI bill, and if not, where or in which section can it be applied? And the second question is, he mentioned issues about bringing numbers down. But my question is, when they were doing their research, did they look into the challenges that were faced by the government in connection with the poor infrastructure, the human resources, and poor corrupt governance of health establishment and national health services at large? Thank you, Chair.
Thank you very much, Chairperson. Let me first welcome the presentation, but I have only one question that I want to ask. Section 40, which covers the information platform of the fund and other section of the bill, such as Chapter 3, Section 10, and Section 11, have articulated the role to be played by research. My question is, what additions should be made in the bill to adequately elevate the research-related concerns which are raised by MRC? Thank you, Chair.
Thank you very much, Honorable Chairperson. Let me thank the presentation from the SA MRC. Just a few questions from my side, Chair. With regards to your inputs on health promotion, are the objectives of the bill not adequate in covering the health promotion concerns as raised by the presenter? As the SAMRC has suggested that the NHI bill should provide for the establishment of the National Health Commission, are you convinced that this should not be established through the amendments to the National Health Act. Then, Honorable Chairperson, my second question to the presenter is, the overriding theme in the MRC presentation is that the health promotion is a prerequisite to successful NHI implementation. Is it not more plausible that the two can be implemented in parallel rather than merely stating that without the one, then NHI should not be implemented? Then my last question, Honorable Chairperson, some of the specific proposals made on the bill are commendable, such as providing for 2% earmarked funding towards health promotion. However, is this type of detail suitable for inclusion in bill dedicated to the founding of the fund, or it can better be incorporated into the regulations supporting the operations of the fund? Thank you very much, Chairperson.
Is it me, Honorable Chair?
Yes, you, Honorable Munia.
I'm still saying, Honorable Chair, as a matter of principle, that when Dr. Dlomo was the chairperson of the Portfolio Committee, we received the list of all organizations that were going to present before us. And there was not there was no MRC1 or MRC2. And I'm still saying that this is the issue that Portfolio Committee as a whole need to follow through. That is the first point. And I think I raised it in the opening because we should not, as a Portfolio Committee, have some new surprises as an organization, as a Portfolio Committee. Let me come to my question. As the MRC, as an entity of the National Department of Health, engage the department on the matters they raise regarding the promotion and prevention, as well as the National Health Commission referred in their slide. In your presentation, you provided Thailand as a good example for which South Africa should learn from on the matters of health promotion. But you have also indicated that Thai Health, which they are equivalent to Department of Health, established the Health Promotion Foundation, not the National Health, not the NHSSO, which on equivalent of South African NHI. What is the reason for expecting a different dispensation for South Africa, if we can be clarified by the presenters? It is not better that a structure such as the proposed National Health Commission or Health Promotion Foundation are catered under a separate provision rather than the opportunistically including such within the NHI legislation. Does the MRC believe that South Africa is the most unequal society, as per some of the statistics and also research? Because those issues of there are people that doesn't have shoes in South Africa. Access to healthcare, gyms and so on, in the villages, in Eastern Cape and all over the countries. They can't even access the sneakers of Nike, which some of you that work for MRC and us can afford. How would we respond to that issues? I'm not raising these issues because I agree with the matter of what healthcare promotion. But I'm saying that in rural villages, people don't have shoes, they're walking barefoot, due to the inequality that we have in the Republic. Lastly, Honorable Chair, does MRC want the status quo to remain of the two-tier systems? With respect to the private medical aid that receive almost 8% to GDP, accounting over 400 billion and saving just 16% of the population. Yet the rest of the population remains not access with that type of support. Because I think this medical aid scheme that receive 400 billion, 8% of the GDP, they should also maybe get 8%. Don't they think that they should get 8% of their money to contribute to health promotion, including to non-members of South Africa? Which in my view, that could be addressed through NHI. What is their view? Thanks.
Thank you, Honorable Chair. I just have one question. Does MRC have any other proposals on how this current bill helps promotion without advocating for new institution that is not part of the NHI fund? Thank you.
Thank you very much, honorable members. I have also neglected to welcome our Deputy Minister, Dr. Siphomiseni Dlomo, who's been on the platform since, I think, just after 11 o'clock, so you're very welcome. I have a couple of things I want to raise with the SAMRC unit. Again, it speaks to the proposed 2% of the total NHI budget that you say must be allocated to the National Health Commission or the Health Promotion Foundation. Question is, wouldn't you rather support the sin taxes, including the sugar taxes, cigarette taxes, and alcohol taxes being earmarked for this specific purpose? Or would you propose that this be channeled through the National Department of Health to pursue the same objective? And does the proposal for the National Health Commission factor in the social determinants of health, as these have a direct bearing on the NCDs? Now, the social behavior model dictates that healthcare is actually a complexity of elements, including health and social determinants of health. If this model is actually recognized by the MRC, why does it seem to be the case that these elements are all expected to be incorporated in the NHI bill? Is it not better for there to be a more coordinated approach to health that includes other sectors such as education, local authorities, water and sanitation, as well as social services? Now, you also, in one of your slides, you argue, and I think it's slide 18, you argue that there are no concrete proposals to achieve health prevention and promotion. Are you aware of the proposal that there will be a benefits advisory committee which will be responsible for setting out the services to be covered by the fund? And why does the MRC seem so certain that the services to be covered will not address the concerns raised? So thank you very much, honorable members, for all those questions. We're trying very hard to make up some lost time. So you can go directly to answering those concerns, Professor Freeman. As well as any other members of your team.
Thank you. Melvin, do you want to start off? There are a few that I can come in with, but between us and Jane as well, we can cover these, I think.
Okay. Perhaps let me say that some of the questions that were asked, I think, do relate more to the other presentation that was given by the MRC rather than this one, which is in particular related to the health promotion issues. And I think that hopefully some of these questions may well have been answered when the previous presentation was done, as I do think that the MRC did say that it was in favor of the NHI, subject to certain conditions being met. And I think that that was then covered previously. So I don't want to go into those questions, but rather focus much more on the issues related to the health promotion questions, and in particular, whether the idea of a National Health Commission or or Health Promotion Foundation should be part of the NHI or not, because I think that that's a very critical issue. But to start with the questions in the order, Honourable Member Wilson was worried about the access to facilities and lack of staffing and so on. And we couldn't agree with you more that that's a problem. And it's a problem that needs to be addressed. And it's a problem that we hope that NHI will help to address by more equal distribution of resources between the rich and the poorest. So that is an issue. But the main issue there, I think, is, are we going to allow those numbers to get higher and higher and higher, and thereby the quality of care getting lower and lower and lower because we're allowing more and more people to get sick? There's no logic in that from my point of view. From my point of view is, let's try and reduce the numbers who need care, and then there will be more money available for those who do get sick and need care. And in that way, the quality of care increases. As I see it, it's logical. Bring your numbers down, quality goes up. Allow your numbers to go up, your quality is going to go down with the same amount of money. That's the logic from my point of view. I'm not going to address the issues of the medical legal and so on, but clearly, yes, that is also, prevention is better than cure. Let's get good services, and then we'll have less medical legal claims. So yes, prevention is better than cure. Around the health in all policies type examples, well, if we take, say, education as an example, what do the education department need to do that might enhance people's health? They do already provide nutrition programs. That would be part of health in all policies and health in all education type approaches. If we come to something like housing, if the Department of Housing is building a settlement, how do we make sure that the houses are built in ways that are well aerated so that tuberculosis does not spread? How do we make sure that they include recreational facilities, which we know are good for health, so that people can exercise physically? How can we make sure that there are parks that are put in place with facilities for people to go and exercise? Those are kinds of examples of where health would work together with other departments, so that the policies of other departments would then move towards promoting health. And one could go into trade and industry, agriculture. What kind of products should we be encouraging that are grown in the population so that our health can improve? Should we be encouraging tobacco crops, or should we be encouraging soya? You know, health then gets involved in the objectives of many different departments. And the challenge of poor infrastructure, again, they have to be dealt with. I mean, we're not saying that they shouldn't be dealt with. What we're saying is perhaps the amount of infrastructure might be less if you have less people needing health services. I think Professor Parry will take the issues around the research issues in the bill. Are the objectives of the NHI not adequate? Well, the objectives does say that we should promote and prevent ill health, but the bill doesn't follow up on that. And that's where the real concern is. We got to put our money and our resources and our commitment where our mouths are or where the objectives are. It's no good to say we need to do this and then nowhere in the bill do we actually do that, or we do it in an inappropriate way, such as expecting that the commissioning agencies will commission adequate promotion and prevention work, when in fact a lot of those decisions need to be done at a national level and need resources at a national level. So if we don't think about those things, then we will get the wrong kinds of prevention promotion. And as I also said in my presentation, if there's a limited amount of money available and there's a huge demand for services, curative services, those committees are going to be under enormous pressure to look at the short term rather than the longer term objectives. Whereas a National Health Commission or a National Health Promotion Foundation will have a much longer, long-term view that it can actually start looking at how are we going to be preventing deaths in the next 10, 20, 30 years? Because that's what we got to do, because the NHI has got to last 10, 20, 30 years, not collapse because we didn't think about what might happen in 10, 20, and 30 years. Whether we should be putting 2% into the bill itself or into a regulation, I thought was a very interesting issue. And I would say that we probably need to say that we need to establish the commission with the percentage to be determined by regulation into the bill. So it might start with 2%, but later it needs to be changed to 3%, and it'll be much easier to change that in a regulation than in the bill itself. So I think it would be a great idea to say that a proportion needs to be put into, a proportion needs to be put into such a foundation, and that needs to be written into the bill, although the amount should then go into the regulation. Have the issues around the National Health Commission been discussed with the Department of Health? The answer to that is yes, but quite some time ago. Perhaps I should divulge that I was, in fact, the Chief Director for Non-Communicable Diseases in the National Department of Health for a number of years. And in that time, we did discuss in great detail with the Minister about the setting up of a National Health Commission. And the then Minister was extremely keen on this. And I do believe that it was also with the Minister of the time's agreement that it was put into the documents around the establishing of committees that I was talking about in 2017. Just to clarify the Thai health issues, Thai Health is the Health Promotion Foundation. So it's works with the NHI to reduce health and healthcare costs. And we're very, very aware of the poverty in townships, the no shoes that the Honourable Member was talking about. The question really is, how does one promote the health of people in poverty? And how do we work with other departments to ensure that the policies that are put in place, yes, help people out of poverty, but yes, help them to get good health? because, you know, we don't want policies that are going to do something economically but impact negatively on somebody's health. So we need to work together and look at the objectives together. Okay. So should it be part of the NHI fund? I think that that's a critical issue. Or should it be part of the National Health Act or something like that? For me, it should be part of NHI because it is so much part of NHI, and that it can be set up so that it is sustainable because of an NHI fund, which is going to exist and which we then can ensure that there's money that is put into this foundation. Without money, it's not going to work. If it goes part of the NHI amendment, so the National Health Amendment Bill, it's possible that it gets set up, but then it actually has no money to operate. By putting it as part of the NHI, we can ensure its sustainability and similarly ensure the sustainability of the NHI because it is critical to the sustainability of NHI. Over to you, Professor Parry.
Thanks for that, Prof. Freeman. Honourable Chair, how are we doing for time? We can go on here and yeah, could you just let us know how we're doing?
Well, we haven't done well with time today, so hopefully you can conclude in another 5 minutes or so. If you do need a bit more, you can inform me, but I'm trying to make up a bit of time.
Thanks very much. I think Prof. Freeman has given a very full answer, so we don't need to say too much more. But first of all, I'd like Jane Simmons, she can perhaps say a little bit more about health in all policies and equality. Maybe you've got a couple of points to add there. Can't hear you. Can't hear you.
Sorry, thank you to Professor Parry and Prof. Freeman and to the colleagues and honourable members. I just wanted to start by saying that I completely agree with Honourable Member Nhi, and I think that very few South Africans have an understanding of the concept of poverty that so many South Africans live in. And I often refer to the example where you look at over 12 million people applied for the 350 basic income grant for the COVID grant, and 6 million people were allocated. And I think that shows to us the extent of poverty if there are 6 million people who are living on 350 Rand a month in this country. And I think that feeds in exactly to with what Professor Freeman was saying and into the health and all policies and the social determinants of health is because how do you work in a community or in a society where there is such devastating poverty and where choice is so limited by poverty and information and behavior is so compromised by the search really for food and survival. I've spent a lot of time working in the last few months with COVID vaccine outreach in vulnerable and rural communities. And I've learned a lot about how do people access healthcare services. But I think if I could just refer briefly to that model that Professor Freeman spoke about in terms of the social behavior communication model. So, you know, and using that model as a way to define the difference between health information and health promotion. And I think we get very confused in the field as what is health promotion and what is health information. Now, health information, if you are suffering from an NCD, for example, hypertension. And I run a project in Bushbuck Ridge where we screen for hypertension in grant queues. And I can say to the person in the grant queue, your blood pressure is high and you need to do X, Y, and Z. That is health information. Is that health promotion? Because that person is in the grant queue to collect their 1,800 Rand. And part of that 1,800 Rand is not the ability to make healthy choices. So moving from that information on an individual level of what you should do, well, this is where we need the model of health promotion and the concept of those other models. How do you move from an individual message of health information to a family message? And there's studies that have been shown in China where children at school are coming home from school with information about how their parents should be eating well. And then you have studies in other places where teenagers want their grandparents to cook greasy food because that's tastier food and salty food. So what's happening in the household? And then we look at what's happening in the community. And what's happening in the community, like Professor Parry says, what are we growing? What are we selling? What is being shifted? What is water access? What is vegetable gardens access? You can't tell people eat chicken breasts and green and lentils if they're living on the kind of choices and income that people have got. And then we need to look at the environmental or the political level. What is happening at the socio level? How is government or an organization like a health promotion foundation working with an NHI to bring all those permutations and factors together so the individual in the middle of these circles can choose to make that behavior, and not only choose it, but they can make it, and then after making it, sustain it. And I think the point there is if any of those levels is missing, that behavior or that positive health outcome cannot happen. And we see it across COVID access, COVID vaccine access, condom access, behavior change in so many things. And I think tying into what everyone does is we have to have a vision that health promotion is bigger than a pamphlet telling you a piece of health information. Health promotion is changing structures and determinants and putting in place all the health and all policies that Professor Freeman has referred to. Thank you, Prof. Parry.
Thank you. And I'll just wind up here because I think lots been covered already. Just, I think, 4 points, very briefly, almost one sentence each. We're not saying health services aren't important, but we're saying that if we don't concretely, cognitively, specifically make space for health promotion, it'll just get crowded out, and the burden of the health service needs will just take all the resources, and actually it will be counter-effective. So we have to make a specific focus. Do we need a new structure? I would say I've been working this field for many, many years. We actually do need that new structure. Much as we don't like to set up new structures, that was Honorable Harvard asked, I think we will get the benefit if we set up, for example, a health promotion foundation. It will pay back in spades. And we shouldn't try to just leave it to maybe it'll get picked up later. It's got to be a specific focus. So I implore you as parliamentarians to really give emphasis to this and recognize the importance of what we're saying in the midst of all the other challenges you're dealing with, all the service needs, the issues about equality, the lack of addiction services that Honorable Wilson talked about. We have to make space for prevention services. So, for example, if we look at the World Health Organization's program of addressing addiction, alcohol abuse, and this is my area of focus, as many of you know, it has 5 prongs to it. It's called the SAFER Initiative. Only one of those prongs is looking at treatment. The other 4, if you're dealing with addressing heavy drinking and alcohol-related harm, the other 4 deal with the availability of alcohol, the marketing of alcohol, drink driving, and one other and pricing of alcohol. And we're going to be having a lot of discussions soon about minimum unit pricing, raising the minimum price at which alcohol can be sold. We have to deal with those upstream factors, and we can't rely on the treatment arm only being there to pick up those needing the services. I was trained as a community psychologist, and we have to look, we can't just go into the river rescuing people who are drowning, bringing them to the shore. We have to go up the stream, up the river, and find out, why are they falling in the river? Why don't they learn to swim? What are the factors that are causing them to get into the river, and how can we prevent that? And if we ignore that, I think, as Prof. Freeman was saying, we really will put the success of the NHI at risk. Finally, around the research questions that was asked by Honorable Geller, I think that's fairly comprehensive, but what we're saying is, in addition to what's in that section 40 and the various sections, paragraphs, we need to make specific space for doing health promotion research to look at how do we, prevent ill health through making cleaner water available, cleaner air. How do we get people to be healthier, even if they live in environments where they can't afford shoes? How do we address that? How do we get shoes to people who haven't got sackies so they can't exercise? I mean, I've been for a 15K run this morning. I can keep healthy, I can live long, but not everyone has that opportunity. So we have to look at health promotion is way more than education. It's providing structural changes to enable people to make healthy choices and address those unhealthy drivers, be they industry-related or other, that bring about ill health. Thanks so much for this opportunity to speak.
Thank you very much to all three of you for coming here today to do the presentation and answering these questions. I'm going to move straight on. The first thing I need to do is to apologize to Prof. Maluleke and Dr. Bengu that we are running late. Professor Perry, you and the team, you're welcome to stay on, or you're welcome to leave the platform as you would wish to do. And I've already thanked you for your presentation. I would then also, after that, to note just for this being in the news at the moment, the closure of Tembisa Hospital after shooting at the hospital. It is a great tragedy, and the Portfolio Committee expresses its shock and convey condolences to the family of the victims. We are going to move on, honorable members, to the presentation of the National Planning Commission, and they will be led by Professor Maluleke, and I think it will be presented by Dr. Bengu. We would have to see how well we do after that. And in terms of there being a moment for lunch, but I think it's only fair and correct that we do not make these presenters wait another 30 minutes. We'll go as fast as we possibly get. With that said, over to you, Professor Maluleke, or Dr. Bengu.
Thank you, Chair. I think Dr. Bengu will make our presentation. Thank you very much, Chair.
Thank you very much, Chair. Honorable Dr. Jacobs and honorable members of Parliament. I just want to recognize the Deputy Minister, Dr. Sponsen Dlomo. I did see at some point Dr. Olive Shisana, the advisor to the President, and Dr. Tulare. And also good afternoon to all attendees. I just want to acknowledge that I am here supported by our Deputy Chair, Professor Maluleke, as you've already met him. And I have also with me commissioners, fellow commissioners, Spusiso Mkwananzi and Tanya Cohen. We all supported by the Acting Secretary of Planning, Dr. Kifile Masiteng, who also leads a team of experts in the form of Ms. Mastura Sedan, Mr. Tabo Mlibatsi, as well as Deputy Director Lizzie Wenguka and Research Assistant Mr. Kwenang Webe. Thank you very much. Let me share my presentation. If I can just get confirmation that it's visible on that side.
Yes, it is. You could maybe put a slideshow. Thank you.
Thank you very much, Chair. Yeah, the presentation here, we will be looking at very brief introduction of the NPC, what we are about. We also will look at how we've taken time to understand universal health coverage and the World Health Organization in terms of its views. We will indicate as well that the NPC does support the principles of the universal health coverage, but we do have areas of concern that revolve around governance, both in terms of the powers of the minister and the appointment of the structures that are important for managing or rather governing the NHR. We will speak about the role of medical schemes as we see, and then sort of touch on the financial matters. And right after focusing on the main areas, we will sort of touch on the Sorry, chapter by chapter responses to some of the issues, whether we support them or have problems with them. The National Planning Commission was established by the fourth administration in 2009 to develop a long-term plan for South Africa. It's established in terms of Section 85 of the Constitution, and they produced the National Development Plan Vision 2013-2012. The main objective is to rally South Africa to achieve the country's development goals over the long term. The current NPC, recently appointed, is made up of 27 independent part-time commissioners appointed by President Ramaphosa for 5 years. It is chaired by the Minister in the Presidency, the Honorable Minister Modli Gumobela. This slide, Chair, just speaks to how the NPC very early on recognize just how important the NHI is going to be for our country. We've never lost sight of this would be one of the most far-reaching sort of transformations in how our country functions. And looking really in terms of the engagements we had, going back as 2016, we hosted a roundtable where the keynote was no less than the World Health Organization lead on health financing, Joe Kudzin, who was accompanied by Ms. Sarah Baba, who gave us comparative scenarios across the globe. And Dr. Tulare quite helpfully gave us a sense of the challenges in South Africa, the successes and proposed working relations in terms of the NPC, the department, and of course, the local office of the WHO. The NPC was represented at the National Health Summit in December 2018. We had a follow-up roundtable on the eve of the elections of 2019, and this was mainly to start building input towards the NDP review report, which we're working on as part of our handover report between two cohorts of commissioners. The keynote was Dr. Tumusime, who is the WHO Director for Health Systems, the regional office, and Dr. Chirombo as well. And the then DG of the Department of Health gave us an update on implementation, obviously as follow-up to the 2016 discussions. The Planning Commission also undertook site visits to Ideal clinics in July 2019 in 4 clinics, 2 provinces, where we wanted to see for ourselves Ideal clinics, how were they being rolled out. We are particularly pleased that we seem to be changing course towards primary healthcare, or rather emphasizing primary healthcare. And one of our performance indicators that we had identified as the NPC was to see how quickly we are rolling out the Ideal clinics, which are planned to be around 3,500 once completed. So we undertook this visit to really satisfy ourselves that this is happening, and we were certainly much impressed and gave feedback to the Department of Health in that regard. The NPC does support the principles of universal health coverage, and certainly how far we have come in this regard. The elements as defined by the World Health Organization are aligned with what we have in the NDP. We do also agree that the financing systems need to be designed to provide all people with access to needed health services, ensure that the services do not expose the user to financial hardship. this is a very important part. We do believe that no one should go bankrupt trying to find healthcare. We really have taken time, and on the quality side of things, as we know that some of the key issues, of course, is that all objectives have to deal with quality of care, cost of care, and of course, it must be accessible. We highlight the quality issue because other inquiries show that in South Africa, we still don't have measures for quality, whether it's in the public or private sector, but it's important. So we tend to rely on some proxies of what is quality. In the private sector, usually it's the hotel facility or the hotel components, basically that I have a TV in my room, the food is nice, and we seem to regard that as quality. That's obviously not the case. On the other hand as well, we may be happy that in South Africa, even if you do not have any means, we do have the public sector as the last resort, if you like, but certainly you cannot go without care. But again, care isn't really just about having access to a clinical hospital, even if you can't afford it. It's still important that when you get there, there are medicines and there are no stockouts. So we do think that the issue of quality must never be underestimated whenever we analyze how our health system is doing. So in terms of us regarding the policy as progressive, we do believe that the issue of fragmented and iniquitous healthcare has to be addressed, and this gives us an opportunity to do that. Our overall concern, as you will understand when you start dealing with our recommendations, is that the bill appears to be drafted on assumption of a perfectly efficient, ethical, and capable state, and tends to ignore the reality of inadequate public healthcare services. We say this because even if one looks and ignores Chapter 10 of the NDP, which is specific for healthcare, every other chapter refers to the fact that we do have indicators that we have a sort of a state that cannot be entirely regarded as capable. This is not irrelevant when we are embarking on possibly the largest program, certainly one of the largest programs that this country will be seeking to implement post-94. We do believe that any institutional arrangement should promote financial accountability and transparency, and this is in the public interest. I will now go into why one of the issues of concern for us are the powers that have been allotted to the Minister of Health. We believe that if this is not reconsidered, we would be exposing both the public and private sectors to be subjected to a potential single source of failure should problems in planning, execution, and monitoring materialize. This is the slide we compiled, basically just looking at all the regulators in healthcare, or at least most. The Nursing Council, the Health Professions Council, the Products Regulatory Authority, Council for Medical Schemes, and when we look at these tabulated by the board, who appoints the board, who appoints the chairperson, who appoints the CEO, there certainly is the minister everywhere. And coming specifically to the NHI at hand, again, the governing body is appointed by the minister. The chief executive officer is appointed by the minister. The ministerial advisory committees are appointed by the minister. The appeals tribunal with high court powers is appointed by the minister. Now, We have no issues. Of course, Minister must have advisory committees, but some of the issues that we don't understand about the ministerial advisory committees is how these will relate with the committees that we assume will be appointed by the board, or at least working with the CEO as EXCO. Indeed, some of them even have names that are similar to those of the ministerial board committees. I'm referring here in terms of Chapter 7, the Benefits Advisory Committee, Healthcare Benefits Pricing Committee, and the Stakeholder Advisory Committees will be appointed by the Minister. If one looks at Chapter 5, paragraph 23, then you do see that the CEO as well will be working with the Benefits Advisory Committee and Benefit Design. There'll also be a Healthcare Benefits Pricing Committee. And without any further explanation, we worry about potential poor definition of roles. So we hope there will be clarity in this regard. On the issue of the appeals tribunal, it really is difficult to understand the intention here. We do believe that we may have gone too far in creating an independent fund, but maybe then have we gone too far in sort of removing accountability? We see the National Health Insurance Fund being given powers that seem to be more at home at Treasury, and through the appeals tribunal, also powers that we believe belongs elsewhere in terms of law enforcement. Now, if somebody has got complaints about the operations of the NHI, you must raise those complaints with the CEO who's appointed by the minister, the board appointed by the minister, the appeals tribunal that's been appointed by the minister, which has got high court powers. We think this is a recipe for problems, for conflict of interest, and it just is hard to imagine what was intended here. And then there's also unusual provision that the board must inform minister of any advice it gives to the CEO. We do not believe these are aligned to best practice in terms of governance, and we do not support and hope they will be looked at again. This, I think, is the point that goes into detail the slide in terms of the Chapter 4 and the appointment of the board, as I've referred to this. Our recommendation in this regard is that Parliament must be involved in appointment of the governing body. And by this we mean the Portfolio Committee on Health, or an ad hoc committee set up precisely for the purpose of appointing the governing body, must be set up to run this process in consultation with the minister. The interviews interviews of publicly nominated candidate must be sort of overseen by the committee referred to earlier, and the successful members could be recommended to the president for recommendation. This isn't unique. We believe it's probably closest to how the SABC runs the process, but it sort of recognizes how important this is. The envisaged size of the NHI fund, the impact of the NHI on the economy and society, the proposed fund allocation process and general complexity of the program require much greater transparency than would be possible under the provisions that are in the bill at the moment. At the time we were preparing this, there was a process where the President's Commission, a Presidential Commission, was in the process of reviewing appointments in state-owned entities. So we sought to marry our proposal with that because obviously it must be aligned. But we were not concerned that that process was also following principles of proper governance. I just want to stress again why we think Parliament involvement is important. The first point, I've got 4 points here. The first point is really just in line with best practice regarding governance. The second point is that Parliament is indeed responsible for appropriation of this huge budget. It's in this bill. The third point is that success and stability of the NHI will depend on strength and quality of governance on the fund. And you cannot achieve this if the person who appoints, as we would expect naturally, that's the person who also fires. The independence is really gone at every single level. The fourth point that is probably less spoken about is the social cohesion that we see. And the NHI is the perfect vehicle to drive this. We all are patients. It's not a question of, let's just say, maybe for lack of a better example, it's SAA, where we channel funds there, but not everyone flies. We all are patients. And this can be a huge necessary rallying point for us to pursue social cohesion. The ideal is to have the NHI protected by all future governing parties, as we see in the national health system in the UK. It doesn't matter which party is in power. The only fight you get is whether the NHS is sufficiently funded. We believe to get there, it starts with a very transparent process that is inclusive in terms of nominations of those board members and in terms of letting the representatives of society in the form of Parliament run the process so that it really is owned by everybody, and we cannot achieve that if it's all down to one department and one person. In terms of moving on to the other issue that we wanted to pronounce on is the role of medical schemes prompted by clause 33, which is brief and vague, but we obviously are aware of discussions that at the time and continue to happen, suggesting that powers of medical schemes will be curtailed. We believe that any reduction in terms of how the medical scheme industry in particular works, or rather that is rendered uninvolved in the NHI, we do not believe that's good for the economy. We believe that we would be missing on an opportunity to basically provide expertise and actually enable those who want to fund their health after paying for NHI. That can only work for the NHI in our view. Simply because if 9 million people pay their taxes and specifically pay for NHI but choose not to use the system, we can't see how that could be a disadvantage to the NHI. If anything, it provides more resources for those who need it at the time that the NHI would be most vulnerable when it's actually starting. I will come to the reasons, because we do understand that there is potential to misunderstand what we are talking about, but we do recognize that we do have very good sort of systems that are getting exported, and it would be a shame indeed if the country that gives this to the world, to the continent, is the one that really doesn't benefit from innovation that will emerge from this. The country does benefit from taxes. The industry employs a lot of people, and really going forward, we need to capitalize on this. The other reason we do believe that this is a matter to be taken seriously is that the WHO itself has got 3 pillars for approaching health, finance, and policy. And the most relevant point is that every country already has a homegrown financing system. So the starting point will be unique and will be relevant to material conditions. Therefore, the mix of fiscal and other contextual factors will also be unique. We just don't see that maybe much of this has been considered. We therefore recommend that the medical scheme industry be allowed to continue operating. The perception of this recommendation, we are mindful that there could be a perception that we want to perpetuate the 2-tier system. It's a valid concern that we faced a number of times when we were hosting those round tables, but it's one that's not valid. Our understanding is that if you're talking about a 2-tier system, it's when those who have health insurance, wealthy, are only seen in the private sector, while at the same time, those who do not have insurance are only sort of exposed to the public sector. This is not what we are saying. We are saying if everybody contributes to this one pool of fund, and if everybody, whether you've got insurance or not, whether you're poor or not, will be seen by public and private sector providers, there is no 2-tier system to speak about. What we believe is the ideal situation is that the public sector will improve to the extent that South Africans will eventually opt out of paying this additional out-of-pocket contribution towards the private sector. We believe that will be the win-win situation. Parts of Clause 49 as well need further investigation, and we believe they may be in conflict with Section 73 of the Constitution, which sets out that the Minister of Finance is the one who can introduce money bills. We support the principle in the bill that money must be appropriated from general tax revenue. We believe this is the most efficient way to do this, but Treasury needs to be involved. The bill is not costed despite concerns that it may be too expensive to implement, especially under existing fiscal constraints. We reserve comments until more details regarding the funding aspects are available, but we also just are concerned that the timelines are ambitious and 2026 isn't far. Now, in coming to chapter by chapter comments, the Chair, this won't take much longer. In terms of chapter 1, we certainly support the principles of mandatory prepayment, pooling of funds, and strategic purchasing, which are the core elements of universal health coverage. We seek clarification about why the State Security Agency would not be covered. We assume this SANDF is because there is a certainly well-established health system on its own, but maybe it's about clarity going forward. The rights of users will recognize and support the notion that the ultimate goals of UHC reforms to facilitate access to health services based on need, not financial means or health. So the subsidization of the ill by the healthy and the poor by the wealthy, we do not have a problem with that. And of course, Clause 6.0 is linked to paragraph 33, which I've touched on. Chapter 3, the NPC does not support the provision that the NHI fund must have powers to invest funds not immediately required. We believe money not spent should be returned to Treasury. The 11 board members that are proposed clearly find, and first and foremost, they have to be conversant with health management, and there is no way that in there you'll have enough experts on investments. We believe it's a recipe for mismanagement of funds, whether through willful, what can I say, corruption, or just not being qualified enough. It's one of the points I was referring to when you say some of the functions that really belong to Treasury seem to be directed towards the NHI. We didn't support that. There is nothing more to say about board establishments. I've covered that. But in essence, it's really that Parliament recommends to the President, board members who choose their own chair and deputy chair, who then appoint the CEO and other executives. This is really not rocket science. It's established. It also just makes sure that the issues of independence and accountability are seen to. And it is by no means intended to take the parts of the minister who are certainly also set out. In chapter 5, it's also related to this. Appointment we've covered, and then clause 20 regarding the responsibilities. We do not support as it stands. We do believe that criminal investigation must be referred to relevant authorities. There is no problem in having a division that obviously looks out for fraud and corruption, but it cannot be the entire system where within the fund there is right up to the appeals level with high court powers. At some point, this must be referred to the proper authorities. Chapter 7 is the Benefits Advisory Committee. And we are concerned regarding the concentration of powers appointed to all officials within the office. I have touched on the lack of clear definition of roles, where the Ministers' Advisory Committee seem to mirror what also is defined elsewhere as the committees that probably are part of EXCO, even to the point of having similar names as it were. Chapter 8, that's also covered again in 31, 33 we have. And then as far as clause 35 is concerned, we do note that the NHI fund will purchase health services on behalf of registered members from both public and private sectors. That's the point where we say this is really not a two-tier system that we're proposing. Everybody pays to the same fund and everybody will be able to see public and private sector providers. We've already covered the tribunal. And in chapter 10, regarding clause 48 on the sources of funding, there might be legality challenges with clause 48B, as all income must be paid into the revenue fund. We believe clause 48.6 should be deleted in line with the recommendation that the fund shouldn't be empowered to make investments of the funds allocated to it. And then clause 49 on the chief source of income, we really do believe that this also needs to be left to the Minister of Finance. And the final chapter where we have comments here is really on transitional arrangements. we do believe there is a hell of a long task of a long list of tasks that must be concluded before 2026. We do not believe that the timelines will be met. And regarding the sequencing of phases 1 and 2, I imagine phase 1 ends this year and phase 2 needs to start this year to 2026. We would be more comfortable if these are based on tasks that have been completed instead of having to follow the timelines irrespective of how far we are. This is the final slide, Chair. In summary, all we are really saying is that we support the universal health coverage principles in full, including mandatory contribution. The relevance of me keeping enforcing this is to make the point that it's not about the NPC wanting people not to all contribute towards the NHI, but it's about managing the risk. We worry that January 2026, that it is really, really unlikely. With our history of execution of projects, it's unlikely that the largest project that we've seen in recent times, we believe we can do it the first time around. It's really, really a hard sell for the members of the NPC who were part of this process. We do not believe that the issue of implementing NHI is really just the first year. It would be years before we can say it has been bedded down. We would like also that to stress that we must build on our strengths, and we do not believe that exemption from competition laws will help. It's been shown many times that where you do not have competition, the quality is not as good as it could be. The price is not as low as it can be. Just to give a ridiculous example, we do believe that maybe if we do not apply competition laws here, then does it mean it's okay for live clinics, Mediclinic, Busamed, Netcare to get together and discuss what they're going to charge the NHI fund for services rendered? We know they can't do that under the competition law. We do not see why that could never be an advantage. We need to fix the urgent regulatory issues in the private sector. The NPC is not saying the private sector is perfect. There are ample examples why it isn't so, including the 5-year health market inquiry, which was completed. But again, the issue of the recommended regulations, the recommended interventions there, many of which have been shown to be drivers of high costs, including the pricing. Still nothing has been done. And that's exactly the examples we are citing when you say we cannot wait while the house is burning now and say everything will be sorted by the NHI. There are problems with private sector, but we need regulatory intervention. And in many instances, that has been examined in detail with recommendations. Point 4 is that the concentration and program execution risks are just too high as they stand in the bill today. I do hope that we will learn from the COVID pandemic, where we did see collaboration between public and private sectors. And when we went visiting for those ideal clinics, one of the sort of changes that impressed us was the Central Chronic Medication Dispensing and Distribution Model, otherwise known as CCMDD, where private sector actually where public patients can go to private pharmacies to have their chronic medication dispensed there, reducing queues in public sector. We're saying this already is in the system. Let's build on it. And it's if anything, COVID, as I said, has highlighted in a manner that all of us as South Africans are now aware that this is possible and actually happening. And lastly, Chair, the NPC is unwavering in its belief that laws should be crafted to withstand the worst inclinations of any public official. What do we mean? We are saying, let us not repeat the mistake of crafting our laws based on who we believe will be in charge. Before COVID, we were already dealing with fiscal problems. And if commentators are to be believed, we are looking at a possibly hung government in 2024. I do not know that if that is true or not. But what I know is that first reason is that we must do what is right governance-wise. But we do understand, of course, that democracy is based on political parties, obviously all fighting to lead government. But we are just appealing that as you sort of take direction in this as our parliamentary representatives, you just think about the worst possible person that you can think of, and assume, would you want to give that person the powers that this bill gives the minister? And I think if we think along those lines, we will all understand that first and foremost, let's come back to the principles of governance in drafting this bill. Thank you very much.
Thank you very much, Dr. Bengu, and to the NPC for this presentation. Honorable members, I have 7 members who want to raise questions. I will start in the order. I'm going to give Honorable Nhi first, since he is about to take a flight. So Nhi, Wilson, Ismail, Sukacha, Clark, Gela, Tembakwayo. Nhi, Wilson, Ismail, Sukacha, Clark, Gela, Tembakwayo. In that order, please.
Thank you very much, Honorable Chair. And I'm so grateful for the opportunity. Honorable Chair.
You are Honorable Nhi.
The Commission also recognized in one of its publications that in South Africa, the poor households are spending a large part of their income on health services and medicine as out-of-pocket payments. This observation is similar of the results presented on financing and benefit incident studies on the National Health Insurance White Paper. How does the Commission propose to address challenges faced by the indigent whilst also strengthening financial risk protection for all and social solidarity for all, not just medical scheme beneficiaries? Your presentation seems to be conflating the role of government vis-a-vis the role of Parliament. It is in the NPC's assertion that Parliament should run government programs. I mean, in the context of separation of power, this is not only impractical, but unconstitutional. Your comments, please. I must also ask the question, Honorable Chair, that arise out of the product of NPC and this is in white paper. It notes that, open quote, the implementation of the National Health Insurance is underpinned by Vision 2030 of the National Development Plan, NDP, which envisages that by 2030, everyone must have access to an equal standard of care, regardless of their income. And that common fund should be enable equitable access to the health care, regardless of what people can afford and how frequently can they need to use a service, close quote. Do they agree with this statement? Or they want the status quo of the two-tier system? Let me just expand, which, by the way, a private sector medical aid, right, receive 8% to GDP, equitable to over 400 billion, saving only 16% of the population. Do the think tank of this country, the NPC, think that the status quo should continue?
Thank you, Chair. Can I respond?
Dr. Bengo, you will respond at the end. Thank you.
I'm trying to. Oh, sorry, Honorable Chair. Let me just conclude. My last conclusion, Honorable Chair. My last conclusion. I won't even take a time. Do the National Planning Commission agree with the President Cyril Ramaphosa when he says, open quote, or they disagree? They must tell us whether they agree or disagree. Open quote, NHI is fundamentally about social justice and will ensure that all our people, whether you are black or white, rich or poor, will be able to access a comprehensive range of healthcare services, close quote. Thank you.
Thank you, Chairperson, and thank you, Mr. Bengu, for a superb presentation. It really is appreciated. I have a couple of things I'd like to raise with you, sir, and particularly you are the National Planning Commission, and I think the title of what you do says a lot about you. So, and I'm very glad you raised the issue that we need a comprehensive health system, not just financing reform. But of course, the NHI is a funding model. And it begs the question, there is absolutely no indication anywhere that tells us how much NHI is going to cost or where the funding is going to come from. There's talks of taxes, there's talks of medical aids, there's taking money from medical aids, et cetera. How does one plan for an NHI when you have absolutely no idea of what the budget is? Surely this is already a huge hurdle to cover. I'm glad you raised the concern that the bill appears to be drafted on assumption of a perfectly efficient, ethical, and capable state. Well, in the current situation, we know that none of these is applicable. There's certainly no efficiency, there's lack of infrastructure, there's lack of resources, there's lack of staffing and accessibility to health systems or health facilities. Ethics, obviously, after the Zondo Commission, are in question, and the capability of the state, considering our current fiscal cliff, is severely questionable. And what you're saying is this tends to ignore the reality of the inadequate health care that we currently have in this country. Would we not better off be taking money and changing those situations first, creating accessibility, building clinics, upgrading infrastructure, making sure that facilities are properly resourced, that they have the right machinery, the right equipment? We are already facing, just in Limpopo alone, 14 billion rands worth of medical negligence claims. And these are as a result of a lot of the inefficiencies. Should we not be addressing that first and ensuring prevention rather than trying to solve problems after the horse has bolted? The powers of the minister, of course, are a huge concern. And again, I'll refer to the current Zonda and SIU report, and I do believe that we are opening ourselves to a can of worms by giving a single person such monstrous powers. But principally, I want to deal with the constitutionality of the NHI bill. You've raised the appeals tribunal with high court powers, and this creates supreme risks. Do you agree that we must indeed maintain the separation of powers, which will allow proper oversight and accountability? I think that this is important. You've talked about sidestepping the Competition Commission. The Competition Commission is there for a reason. And I think, and you can tell me, will the NHI bill's single purchaser system not definitely require the Competitions Commission, because we are now giving people who are appointed by the minister the sole mandate to purchase on behalf of the health system, which is going to cut out a lot of the current suppliers if we are not careful. Constitutionality, there's a lot of discussion about taking people's freedom of choice to go to the doctors that they want to go to. And I give myself in this example. My family has been going to the same doctor for 22 years. He knows my background. He knows my history. He's helped deliver my children. I don't want to go to somebody else. I don't want to have to start a 20-year process from scratch. And there is concerns by a lot of people that the freedom of our choice will be taken away by the referral system. And lastly, the NHI bill, and I think you've raised this in your presentation, it affects many, many other acts, both within the health system and in the entire system as a whole. What do we put, the horse before the cart or the cart before the horse? Which comes first, the egg or the chicken? Surely we should be having a very, very intense look at the effect of the NHI on all the other acts that it's going to impact before we should be proceeding with this process, because we are going to end up with a situation of constitutionality. We are going to leave ourselves open for loopholes and potential irregularities. Is this not a step we should be taking first? And lastly, in terms of WHO standards, regulations, and agreements, we have to look after foreign nationals as well. Okay, we can't leave people, regardless of who they are, where they come from, regardless of their circumstances, sick and dying on the streets. And there's a constitutional issue here as well, in that the NHI states specifically specifies things like emergency care, which I think in terms of the world standards at the moment is also irregular. That's basically from me. Thank you, Mr. Bingo, and thank you for a great presentation.
Good afternoon to everybody, and thank you for a very, very, very thorough, informative, and well-presented presentation. Due to your presentation, you know, I've actually cut the amount of questions I have because your presentation was so thorough. So one is that, you know, do you feel that the NHI in its current form is sustainable? You know, do you feel that, or would you say that, you know, the NHI model, which, you know, has been a bit covered by my colleague, Honorable Wilson, but can you really say, you know, that the NHI bill in its current form will be providing a health value-based model? You know, and that's, I think, what South Africa actually needs now. We all know that the NHI is a, you know, funding model, and I want to actually stress the issue of the fact to say that we need, you know, something that's actually relating to, you know, the provision of a good health, you know, to our country. Secondly, noting that the NHI bill will be sourcing funds from taxes, and the tax base in South Africa is relatively small. I stress this because do you feel that a pool of taxes will be sufficient to carry the bill, since presently, you know, we have the private sector that is running parallel to the public sector, and that's taking, you know, the load off the public sector. And therefore, we find that obviously, you know, we have the citizens of this country and non-citizens of this country actually getting some sort of quality healthcare. So do you think that this will be sufficient, or maybe government should rather start concentrating on the, you know, increasing employment opportunities rather than, you know, stifling, employment, and rather concentrating on taking much more from the tax base? Now, my colleague has stated and covered me a little, you know, when it comes to infrastructure, what is your opinion? Now, we know that, you know, we have a major shortage of healthcare workers due to community service doctors and nurses not being placed simply because of budget constraints. And considering the NHI bill is a fund model, but I'm sure we're not going to be doing what we really require. So would you recommend that, you know, we first fix up what is going wrong in our health system before we actually think of implementing the NHI? And, I'm going to just stress the one point is that the Office of Health Standards Compliance cannot even manage to monitor 20% of our healthcare facilities. And, under the NHI, this will be even more work for the, for the OHSC. And do you think that, we will actually have health facilities that are really compliant and providing healthcare services under the NHI, or, we will not be reaching the targets? I think you highlighted over and over again that, you're not going to be seeing the NHI actually materializing in the space of time that is projected. So you feel, that if this will actually stifle or impact health services to communities, as most public healthcare facilities will not be sufficiently running under the NHI. My major point that I want to ask you is, under the bill's current governance and organizational structure, we know that with the corruption and the SIU investigations and, the digital vibe scandal over and over again, where there was lots of swindling and corruption in the funds, do you feel that or recommend that the private sector be included on the bill or on the board? I mean, you have touched something on it, but I want to know, what is your actual recommendation? Do you recommend that Parliament serves as an oversight to mitigate the threat of corruption? Thank you, Chair.
Thank you very much, Chairperson. Just a few questions from my side. The first question, Chair, is in one of the Commission's publications, you spoke about the benefits of economies of scale in terms of buying power to negotiate prices with the manufacturers, with the wholesalers, with the retailers, and dispensing clinicians in the context of the NHI implementation. In fact, you were in support of the NHI in this context. Now, my questions are, has that view changed from the Commission? And then the second one, if so, has the Commission done further detailed research to refute this initial stance on the benefits of economies of scale and the buying power? Then my second question, Honorable Chairperson, to the Commission is, it appears that the NPC presentation is based on an implicit assumption of public sector health services are all bad, inadequate, and private sector all good. On what basis is this conclusion based? Then my third question, Honorable Chairperson, is, does the NPC see health a tradable commodity, or do they support the notion should be regarded as a public good that is not dependent on the whims of market forces or market fundamentalism? Then my last question, Honorable Chairperson, is the NPC asserts that the private health sector contributes significantly towards tax and employment. Does this imply that no sectoral reforms must be implemented because the assertion is that the private sector is sacrosanct and hence should continue unchecked despite the social and health consequences on the greater population? Thank you very much, Chairperson.
Honorable Clark. Honorable Clark.
Thank you, Chairperson. I'm not going to put my camera on. I'm having problems with my signal. Just the following. Thank you very much for the presentation. It was a very informative presentation. And what I really liked about the presentation was that there were some real recommendations put forward, and not just telling us about the NHI bill that we, in terms of context that we all know. So in the presentation, there was mention of 3,500 ideal clinics rollout. Now, I would like to know, how are we going to make sure that those clinics actually conform to the ideal clinic model? Because in my view, every oversight I've done, none of these clinics actually conform to that document that we're supposed to roll out certain aspects to comply. That is not happening. And how is that going to be part of, how are we going to make sure that these clinics actually conform? Then again, we spoke about the greater, we spoke about the powers of the minister and the implications thereof. So there is mention in clause 31 that's open to constitutional challenges. And what are the constitutional challenges that you are referring to in the clause? What are the major risks of the current role of the minister as stipulated in the bill? And what I would also like to ask the presenter is that my previous colleague did mention the topic, but I would like to know, would you say that if Parliament played a role in terms of the establishment of the board and the committees that need to be in place, that would be far more transparent, so that we can ensure that the accountability of the administration, the accountability of the board and these committees are taken into account, and that we can then ensure that fraud and corruption that has taken place, as we well know, over a period of time now in terms of PPE and the previous minister that was implicated, does not happen going forward if this bill had to pass. Then if I could ask, and we look at the feasibility and the costing, and that comes up in every presentation that we have and discussions and questions. And I think it's an extremely important point. I mean, is there any available data that we've done any social economic impact study, and to see what the outcome of that was? And when we speak about costing and feasibility, in this presentation, there was a mention of 9 million taxpayers. I don't think that's nearly correct. I think we've got around 5 million taxpayers in this country at the moment, because we've also experienced mass capital flight in this country, which needs to be taken into account. And to cost this bill, I mean, where are we going to get the money from? I mean, there must be some kind of avenue in terms of, for example, raising taxes. I mean, what would that percentage be? Are we going to raise VAT from 15% to 20%? And that would have dire consequences on the poor of the poor, because cost of living in this country is at a point now that's so many people, the poor of the poor, can't afford to put a plate of food on their table these days, and the middle class themselves are really battling to afford what needs to be paid in this country just to survive. I mean, we heard in the previous presentation that 6 million people received the 350 Rand grant. I mean, would that be taken away to fund this bill? You know, there must be some feasibility costing so that we actually know what this is going to cost us and what implication the costs are going to have on the citizens of this country. I mean, would it not be far cost effective to take universal health care that's already in place and make sure that the environment that we operate in is of quality and that we supply quality health to the citizens of this country? And I'm concerned about these things. Are we going to cut basic education's budget in order to fund this bill? No, we must be told what's going to happen. Thank you very much, Chair.
Thank you very much. I hope I'm the next speaker. Let me welcome the presentation. I've got few questions that I want to ask. My first question, why is NPC not comfortable with NHI fund managing a budget that is estimated at 450 billion, whilst it is happy that National Treasury can manage the entire budget of government? SARS manages even more. Can the NPC explain more on that? My second question, can the NPC explain its understanding of Section 10C? Is it not a misinterpretation to assume that entire health expenditure of 400 billion will be used for NHI? Does that not go against Section 33 of the bill, which talks about medical aid paying for services not covered by NHI? My third question, the NPC seems very opposed to the minister as executive authority having the power to appoint the board and other structures of the fund. If the minister is constitutionally empowered to be responsible for the health and the fund is proposed as health entity, why is this such a huge area of concern? My other question, Chairperson, can the committee be assured that the advice crafted by the NPC is free of prejudice? I ask this because there is evidence that some of the commissioners, entrepreneurs in the health sector, including the presenter himself, can we get assurance that NPC is looking at the matters of the health reforms wearing a public interest lens and not a pro-capital and business interest? My last question, Chairperson, does the NPC realize that the challenges in the public health system is due to the cleaning off of a specialist to the private sector? Is this not a direct result of taking some of the best doctors to serve the few in the private sector leaving many waiting in the long lines. Is a national planning body not aware of this fact? Lastly, Chairperson, Section 15 of the bill, where the function and powers of the board are covered, does explain that a comprehensive healthcare system is required under NHI. In the NPC slide titled Quality Healthcare, the presenter appears to find these provisions inadequate. May I get some clarity as to what additional provisions should be catered for in the bill in order for NPC to believe that their concerns are addressed? Thank you, Chairperson.
Thank you, Chairperson. Thank you for the presentation. I've got only one question based on the visits to the ideal clinics, and including those 3,500, but specifically on the 4 clinics in 2 provinces where the presenter made mention of the fact that they were pleased by their findings. And I'm just interested in knowing what are those attributes that he can mention that certified this pleasing aspect of the findings, because there's nothing pleasing in clinics as long as they are not open for 24 hours and 7 days a week. So what is your recommendation on the issue of 24 hours and 7 days a week of the opening of the clinics? And lastly, to say, should the same inquiry be extended to all clinics in all provinces with the specification to the rural clinics? Will the same findings that you arrived at be arrived at to certify validity and reliability of your own findings? Thank you.
Thank you, Honorable Chair. Just one question. Can the NPC explain how they view the inadequate human capital in the public sector? If the people pay for services and not use them, do they not take away health professionals with them and leave the majority with no care as it is happening now? Thank you.
Thank you, honorable members, for those questions. I still also have a number of points to raise with you, Dr. Bengu.
Yes.
Before you're allowed to respond. Well, let's hope we'll be able to complete this by 1,500 hours, which would be 1.5 hours.
Okay.
You had started. But let me raise my points, Dr. Bengu.
Thanks, Chair.
Firstly, let me appreciate your input. And secondly, as you are aware, you're the custodian of the NDP 2030. Thirdly, I've noted a number of contradictions and inconsistencies between what you have presented and what in your Commission's previous research and publications on related matters. And then based on your recommendation for a multiple fund UHC system and our knowledge of the NDP proposes, amongst other things, that the UHC needs to be complemented by a reduction in the relative cost of private medical care whilst improving quality healthcare for all. Are you therefore telling the committee that it should continue with the current health system that is highly fragmented in financing and in provision? Have you considered through empirical work opportunity cost of your recommendation, especially for the poor? Are you saying that the Commission is happy about the current inequities and differences in financing and benefit incidence of healthcare in South Africa that we all understand to be pro-rich, with the richest population receiving bulk of total healthcare benefits available in the national health system, despite having a relatively low health need compared to the poor. How do you propose the committee addresses social solidarity and financial risk protection for all, not just the medical schemes member? If I'm going too fast, you may please indicate. I think I am going a bit fast for your writing there. Sorry about that. Thus, how does your recommendation then align to the NDP goal for quality of healthcare for all in South Africa, when the bulk of healthcare financial resources are serving less than 16% of the population? Are you aware that the same medical scheme beneficiaries also sometimes use the state facilities when they run out of benefits, or when they can't afford medical schemes cover at all? And can you please explain why it believes that medical schemes are good for the economy? You phrase that point. Have you ever considered the catastrophe, financial catastrophe that members of the schemes are facing as schemes abdicate from covering members according to their health entitlements? Now, we understand that the current two-tier health system, which you define differently, has and continues to cause a myriad of health and social inequities for the population. I'd like to get your view on that, since it seems like you do not recognize this based on the proposal that medical schemes and an advanced private health system must continue unfettered. And it seems that you're opposed to the fund being empowered to make reasonable investment decisions. You've explained that medical schemes currently do make those. They invest the monies of their members. We haven't seen opposition to this ever prior to this statement of yours. And that means it appears to be that the recommendation is meant to stifle the fund's flexibility in meeting its mandate rather than any other reason. You can just maybe explain the rationale behind this. And why do you object to the fund investigating fraud being committed according to clause 22E? Clause 22E does not say that the NHI must be a law enforcement agency. It just says that NHI must investigate fraud. There is already collaboration with all law enforcement agencies, and they pursue all matters referred to them. And then very lastly, is it the view of yourselves? Now remember, I started by saying you have a responsibility, that you're charged with this responsibility plan for the nation. Are you saying that this organization yourselves then failed to assist the poor, where we see this bill as being pro-poor and trying to assist our people to be able to access quality health care? So if you can please also clarify that. I know there are many questions asked now, and we leave that in your capable hands, and let's hope you can get to most of those, and any of those questions which you are not able to get to, I might have to give you more time, but if you're not able to get to it, to also then respond to us in writing. Thank you very much.
Thank you very much, Chair. I hope I captured all of them, but I did try. Some of them are probably best answered in clusters, but I will start with Honorable Chili's questions. And I suppose the easiest one to start with is the question whether the NPC agrees with the President that the NHI is fundamentally about all of our people, without a shadow of doubt. It's our view. It's not only in the NDP, in this presentation, that point was made. And we did state this obviously covers quite a lot of, it's one of the thematic ones, that in the presentation, I made the point that the perception of a support for a two-tier system I anticipated, but on many occasions I kept stressing that cannot be deemed to be the case, mainly because we do state that everybody must contribute towards the NHI. And if we thought differently, we wouldn't be saying that. So that certainly covers any concern that we might be worried, that anyone might be worried that we saying we want a two-tier system. The point we are saying is that the risk of not managing this gradually is just too high that this will collapse in the first instance. And we worry that there will be no second opportunity if that happens. We have health professionals who are in demand all over the world, and we have to sort of bear that in mind. So, and we stressed many times that we're fully on board with all principles of universal health coverage, not only on contribution in terms of revenues, the pooling of funds, and even the strategic purchasing. So I hope that clarifies it. Our issue is basically to say, let's build from where we are. And we do have not perfect, but it's a functioning healthcare financing system. Now, the question also about Honorable Munyai, he says the medical scheme industry at 400 billion is 8.1%. This is not my understanding. My understanding is that the medical scheme industry is around 200 billion per annum. The 400 billion is actually a reference to, in 2019 figures, I suppose, both public and private sector, clearly the figure keeps going up. But my understanding is that the total spend of the country is 8.5% of the GDP. That's all healthcare. So I think that's the one point, unless I'm wrong. Yeah, the issue of financial risk protection, it's certainly aligned with what we are proposing. We're not conflating the role of government and parliament. We certainly are not infringing the point about powers of separation, but it's about making sure that accountability is agendered. We have a unique opportunity of doing this at the beginning. And I did stress here that what we are recommending is not new. It's exactly how the SAPC board has been appointed, for example. It's not the only one. And we also further said we need to compare notes with the Presidential Commission that advises how governing bodies are appointed. That is relevant because it speaks to accountability at every level. There is no suggestion that the minister will not be able to take any decisions, but it's really about separating the appointment on the highest body. And obviously I touched on the element of social cohesion and getting the public to participate. The question about equal standard of care just goes straight to we're not saying that. I think it's aligned to the two tiers, a two-tier system. It's clearly what we are talking about when we say what we are proposing is exactly what we've seen happen with COVID, where people without health insurance are able to use private hospitals because this is based on need. It's again the point I made is subsidization of the sick by the healthy and of the poor by the wealthy. So it's really just clarification. Honorable Wilson's question. Yeah, I think the question that there is no indication how much NHI will cost, I suppose that's not the question that should be directed towards the NPC, but it's certainly a point we make that we would rather make further comments on the financial provisions once there is further information that comes up. So it's difficult for us to basically say whether the funding will be sufficient or not, but we will reserve comment until the information is there. But what I know is that the basics of health economics basically do say that no government can provide all the healthcare its citizens demand. I do not believe we'll get to a stage where South Africa can afford every little bit of service all of us need. This is exactly what takes us to the whole point of rationing of services. The case of Subramani is based exactly on this, where the Constitutional Court itself said, everything considered, having looked at all the issues, the state is not wrong in denying care. So I wouldn't like the association that NHI should only be considered when South Africa has got all the money. This approach must be grounded on the realization that universal health coverage is a destination. It's not, sorry, it's a direction and not a destination in itself. And that covers my view in saying the argument that we must first fix the infrastructure before we look at the funding, I don't quite support, because we need to start moving in the right direction. It's almost like saying SANRAL should actually not build new roads until it has got money to pave or tar every single road in the villages. It can't be. We have to start the path of bringing in the right reforms, and it cannot be that we wait until all the money is in place. Now, the issue of infrastructure is definitely an important and relevant one. That is why we made those visits to the ideal clinics and have that in our performance indicators, because we realize that the infrastructure is important, but I don't think we need to wait only until we have got all the funding before we can start. Yeah, so that covers, I think, Honorable Wilson, the question about why don't we wait until we fix the other part. And then if I look at that the NHI bill affects many other acts, yes, I suppose it's in the nature of government and governance being so totally integrated to start with. So that is not surprising, but it speaks to exactly why the different departments, the different arms of government should be involved. What Honorable Chilidzi interpreted as what's this, where we talk about violation of separation of powers, is actually explained by Honorable Wilson in saying this is cross-cutting. That the NHI is everybody's challenge. If anything COVID has done, COVID has shown what health policy wonks have been saying for years, that healthcare is equal to the economy. And in that regard, we've seen how it's affected employment. People have lost incomes. Education has been affected. there isn't a single component of society that hasn't been affected. But then to come back and say only the health ministry must deal with health issues does not make recognition of the point I've just made. So when we say Parliament must be involved, when we say Treasury must be involved, it's in recognition that health is a cross-cutting issue. A lot of our health problems, for example, have got their genesis in sort of socioeconomic determinants of health. It's about the sanitation that's not being provided. It's about early childhood development. It's about a whole lot of other non-health issues that determine how well our nation will be. So that, for me, is the answer I can think where we say healthcare must only just be dealt with by one department. It cannot be, it shouldn't be, and just even on governance perspective, but that does not mean we don't have a minister who should be accountable. But the point is that is now at implementation. But the issue of setting up the governance structures remains relevant. Regarding foreign nationals, the NPC, we didn't even comment on that because we are fully in agreement that everyone who's in the country needs to have access to healthcare. And of course, the classifications are there. In some instances, it's about recognition or making provision that this could be on the basis of emergency. But we are not supporting a situation where foreign nationals are denied care. Honorable Hasina Ismail. Yeah, the question is NHI in current form, is it sustainable? I don't understand this question because the NHI isn't in place, unless the question is whether, as it's proposed in the bill, is it sustainable? This is a hard question simply because we are here to point out the gaps that we believe should be closed, which in the first question about sustainability is, of course, the financial impact. And we don't have that in the bill. So it's a question that's not easy to answer, simply because the sustainability has a lot to do with the funding model that's being used. Will it provide value-based care? Certainly some elements of the bill lend themselves to that. And I'm talking about strategic purchasing. Strategic purchasing basically means that right from the perspective of who will be the service provider, that's about contracting. They will have to meet certain parameters for them. And surely the question of how much it will cost government to buy services from them relative to benefit in terms of quality, that speaks to the value-based question. And all I'm saying is that elements that in turn pushing us into the value-based arena are certainly there. But of course, it's down to implementation. And the question, of course, is about the tax base. The issue of a tax base comes up not only in healthcare, but everywhere. But that's the reason why we are saying those who, after paying for NHI, still want to pay out of pocket for healthcare services, they should be allowed to do that, certainly in the first instance, because services that they've paid for but they don't consume mean that's more for those who are dependent on the NHI in its entirety. This is after tax spending that we are talking about, but also just to manage the risks that would arise if everybody on day one rocks up looking at the NHI for services. So the question, of course, again, whether we'll have compliant facilities. What is helpful is that, of course, we do have the OHSC that's tasked with this role to make sure that even before facilities are evaluated, that they are capable of providing quality care. At the very least, it means the intention is there. It's still early days for the OHSC. There's no reason to believe that it will not rise to the challenges. Certainly, it's quite onerous what it has to deliver on. But again, for the OHSC to deliver on what it's intended to do, it's very important that it must be independent, must not be compelled to give pass marks to facilities that are failing. The issue of corruption, Ms. Ismail, I mean, I don't think anyone can deny that we have got a corruption problem in this country. And all I can add is that it exists in the private sector as well. There's no intention to suggest that it's only in the public sector. On the other hand, as a general principle, I mean, you don't really have public employees bribing each other. It's the private sector by and large that perpetuates that. It's a problem that needs to be dealt with. And Honorable Sokacha, yeah, no, there is certainly no change in the view. I suspect you misunderstood the context in which the NPC has previously referred to the acquisition of services from pharmaceutical companies, whether it's suppliers of medical devices. Or the point that was being made here was that for the private providers of care who may be in private sector, the answers we've heard before, for example, is that they are able to offer reduced prices to the tender system simply because they are able to derive higher markups in the private sector. So the context in which this came is that, well, one, it is absolutely important to recognize that the issue of the private sector existing alongside the public sector is not new. It's existing, it is here. And it is fair to expect that even the practitioners who are in private practice but providing services to patients referred by the public sector NHI fund will certainly have to expect and will be negotiated to provide those services at a lower rate for the NHI fund than they would be paid by the private medical aid fund. So there is no change. I just suspect it was probably misunderstanding in context in which that was raised. There's the point here that the presentation comes across as if the public sector is all bad and the private sector all good. This is, I'm sorry if it came across that way. It's absolutely not true. The point I made in this regard, I said, for example, in this country, we just don't have the means to measure quality. I was saying it's easy for people to think the private sector is better simply because the hotel side of the facility are much better. I made the example of a TV in my room, meals, a menu that seems better, but those aren't the core quality measures that matter in the private sector or the public sector in any case. So the appeal for quality measures to be looked at, that applies across the board. And it's essential because that was me confirming that we don't have the right measures. I can go on and say, actually, as far as teaching hospitals, they certainly remain very good for for dealing with the highly complex sort of conditions. I could never say the public sector is all good, is all bad, when it actually trades. The practitioners were all in private practice. It wouldn't make sense to say that, but certainly what is undeniable is the working conditions are different between the two. Now, to what extent do those drive migration to the private sector? It's all there for us to think. But I had the good fortune of being part of the health market inquiry, and our findings are very clear as well regarding parts of the the cooperation between the two parties. There are medical schemes that pay for public sector provided care. So I apologize if it came across as if I suggest the private sector is all good. I actually did say that there were quite a lot of issues, but I gave that in the context that who is to blame? It's actually the department that's responsible for regulation that still hasn't moved on some of the recommendations that have to deal with the problems that are there. And the example I want to use is that of pricing. Simply because all of us on this call know that you can never know what it's going to cost you whenever you go for healthcare consultation. But there is a solution proposed that would give a reference price list that would be distributed so everybody gets a better chance of what it would cost them. And we're able to show that that actually partly drives the high cost of care. So it's a question of saying there is homework for regulators to do their part to make sure that where the private sector is wrong, and there are many areas that it is, the regulation must kick in. Does NPC say health is a tradable good or must be subject to market fundamentalism? Absolutely not. It cannot be subject to absolute fundamentalism. That's exactly why we support all principles of universal health coverage, because they say nobody must go bankrupt looking for healthcare. Everyone who needs healthcare must have it. And of course, the issue of strategic purchasing has to do with the fact that it cannot be profit at all costs. It's about using the power to negotiate. It's about also regulating the prices, which takes us to how the pharmaceutical industry works. It's highly regulated, and we see how prices have come down. Now, but outside of that, nothing seems to be moving on the other aspects of healthcare. So we don't say healthcare must be subject to market fundamentalism. Honorable Clark, the issue of ideal clinics, how will we make sure that they conform? Well, this is really a management issue now. The clinics that we went to visit, understandably, it's only 4. But the intention was not to rate the entire system, but was just to say how do these clinics differ from clinics that we grew up knowing that are not the so-called ideal clinics. One of the things that these clinics are susceptible to is that the clinic can be worked up to reach the level of certification or accreditation as an ideal clinic, but we did see that it's possible for them to slip back. Again, it's a management issue. It's a question of the need for them to be visited regularly without any warning. It's about the OHSC also ultimately getting involved. But the point that we are making is that when one looks at the targets or objectives that clinic managers needed to meet, we felt that it was a very good checklist that made sure that from cleanliness from equipment that not only must be on site, but must be seen to be working. We liked what we saw in that regard, but we are not saying all of them are like that and that they are not prone to having their standards actually sleeping and going back to the non-ideal status, if you like. On the feasibility and costing, I don't think that's the question that should be going to the NPC. We are just as eager to learn how the NHI will be funded. And I refer to 9 million medical scheme beneficiaries, not 9 million taxpayers. And even if then the question as to how do we know that how do we know if most people don't like quality in the public sector? The only thing I can think of the top of my head is basically, other than general comments, it's the general household survey, which was done, and it. Let me see if I can get this, because we referred to this in our written submission, maybe not in the PowerPoint. That in 2017, the general household survey indicated that a quarter of households indicated that they would go to private doctors, private clinics, or hospitals, and that 97% of households that attended private healthcare facilities were satisfied with the service provided. This is as opposed to sort of 27%. And then 5.3 households as opposed to 0.6 that attended public health facilities were very dissatisfied. And then nearly a quarter of South African households had at least one member who belonged to a medical aid. So the point is, these are really just proxies, but they seem to suggest a preference for private sector. And the question is why? And we believe that the NHI can be used to be the tool that starts to balance these issues. Honorable Geller, why is the NPC not comfortable that NHI fund manages for the budget versus SARS? Your comparisons about the NHI fund were interesting to me, because you compared them with SARS and you compared with Treasury. Treasury and SARS are staffed by professionals who are primarily trained to manage funds, which wouldn't be the case with the NHI. And I have touched on this by saying it certainly can't be okay that we create a fund as big as this and say everybody else hands off. There are issues that we need to recognize that these issues are cross-cutting, but ultimately you want people who are primarily fund managers to manage the funds. And I suspect this question applies to the chair's question regarding the investment, our preference that investment of unused funds must remain within the NHI fund. We do not think that is best practice. And again, it's not a precedent. I have been a chair of the Road Accident Fund. The Road Accident Fund, it's in the Road Accident Fund Act. It cannot acquire any facility. The only facility it owns is the building, and has not been allowed to acquire more, and it cannot make any investments. None of these recommendations are novel, but we are trying to get the best out of our experience across government to bring this to reality as far as the Road Accident Fund is concerned. And the issue of not wanting the minister to have powers to manage is, first, it's not true that the proposal is that minister mustn't manage, but we are talking about checks and balances, risk management principles that make sure that there is protection against what needs to be done. Can committee be assured that advice is without influence? And I think there was a very specific reference to me. I can assure you that the advice the NPC put forward is influenced to the extent that we had lots of engagements with people from all sectors of society. And that's how I started my presentation. And some of those will have been private sector people. The bottom line is that, again, I need to explain how the NPC is appointed. Except for the minister, who is the chair and is there in his capacity as, obviously, probably you could say the only one with an official political position. All of us are appointed as individuals, as citizens. We do not represent any organization. We are there with our jackets. What it means, and it's deliberate, that we should come from all walks of life. And part of the commission includes people like me who are in the private sector. That's disclosed, that's out in the open. But if it's relevant to the question of what I do, I'm not in the medical scheme industry. I don't own or run a medical aid. I don't own or run a hospital group. I work with them, I consult, but it's not an issue. There is no reason I would prefer them over what is good for my country. I have a history spanning many years. I've never been fully employed in private practice in public service, but I have worked as what I call national service in the public sector in many forms. And the extent to which further information is required, that's fine. But the message here is that commissioners who are active in the private sector are in the commission deliberately for a reason. It can't be that the expectation is that you have only public sector commissioners, and the rest of that is really up to each individual's ethics. But I can assure you, within the commission, it's impossible to influence any decision and be driven by financial interests simply because we don't influence spend. We provide research-based policy advice through the minister and the presidency. And we do have checks and balances against each other. Some of the debates could be amusing because the fights can be quite intense among commissioners. But I can say that all of those fights are based on ideas. None of us can all be, it's just impossible that a group of 27 people can all be, have the type of thinking that's perfectly aligned. But that's exactly the reason why we are appointed to come in that regard. And yeah, PS section 15. Yeah, about the quality of healthcare, what other provisions must we suggest? I think, Honorable Geller, the main point I've touched on that I think the first step is to really establish quality measures, public sector, private sector, because you can't manage what you can't measure. And that's the biggest challenge. But I'm very pleased that in the NHI bill, you do see that the quality has been considered, whether it's through the health technology assessments, whether it's the intention that people who are contracting or companies that are contracting will have to prove not only the cost part, but also that they will provide the quality that will serve our nation. Honorable Tembekwayo, clinics, yes, the issue of clinics being open 24 hours, 7 days a week is absolutely desirable. I don't know if it's always practical. For example, the ideal clinics that we went to see, this was a question that we were interested in regarding how this is managed. You, especially the ideal clinics, the bigger ones, you would find that there is one central clinic that is bigger and better staffed, but after hours would then continue to operate throughout the night with the smaller satellite clinics around it referring to the hospital. I think the model in that regard is sensible because it's not possible, I doubt, that all 3,500 clinics can run 24 hours, but it's important that within a certain radius, there must be a clinic that will run 24 hours with the necessary references. The inquiry should be extended to all clinics. That wasn't the intention to rate the system. It was to say, we want to have them monitored, at least the implementation, because we regard primary care as so important. So it was about seeing what an ideal clinic looks like. And the issue of being inspected regularly probably falls elsewhere, certainly under the Department of Health. I would imagine the OHSC is the place, but the NPC's interest at the beginning was really just to say, how fast are we rolling them out? We were already late in 2019 based on the target, and we probably will be interested to see how we are doing or how we have done since then. But I've already touched on the fact that sometimes they do fall back after having reached the accreditation status. Honorable Harvard, about the inadequate human capital. Yes, the issue of health professionals is a concerning one, but that's also the reason why the bill makes sense in sort of saying healthcare will be acquired from public and private sector. It's regrettable that human capital tends to flow with the direction of the private sector, but again, it's up to the regulator to sort of manage that process. Now that, I don't know to what extent that can be reversed, but the presence of occupation-specific dispensation, the RWOPs, remunerative work outside public service, we all have views about this, but it's obviously intended to manage the shortage or the migration from public to private sector. But Honorable Harvard, this is exactly the reason we worry about January 31, when this humongous system looking after 60 million people, all healthcare services, on January 31, a message comes through that there has been a system glitch. None of the healthcare providers have been paid. That's what worries us, because I can assure you the next month, we will have scores leaving the country, and it's a problem that we're facing already. So the issue of management of human capital is an important one, and I do hope that the NHI, in basically securing services from private sector practitioners, certainly is on the right path, but not so much on terms that are unreasonable to the public sector. We have to look after the fiscus. Chair Jacobs, I think yours were the last questions. Look, I heard your reference that the contradictions and inconsistencies. I respectfully disagree. Our solution doesn't seek to perpetuate the inequities, and I was at pains to say this right at the beginning, right in the middle, and at the end of our presentation. And it speaks to the issue of saying the mandatory benefit, the mandatory contribution towards the NHI is wholly supported by us. And I may say what didn't come out in the report simply because these were the fights that were happening in the background. Some of the proposals were, well, there was no question that the medical scheme industry should continue. And the only reason I'm focusing on it in this presentation is simply because the other parts of healthcare, which is the delivery arm, whether it's the hospitals or the professionals or medical device or pharmaceutical suppliers, those are catered for in the NHI. So this is the only one that's questionable. But the debates were so heated. The important thing is there wasn't a single commissioner who felt that medical schemes should be done day one. The debate was whether should that be in perpetuity, or should that be a horizon of 10 years, and whether you should then start reviewing that. Because a project this big, implementation is not a first-year issue. It's not a 5-year issue, it's a decade at least. So the question is whether there should be a horizon that can be argued. We affirm that if anyone thinks on 1 January 2026, this entire project having the country with an unfortunate history on delivery, we will get this one right. It's just hard to believe. And I did say it was a hard sell to commissioners who were tasked with looking at it. Now, Chair, certainly the social solidarity and financial risk, those are basics of universal health coverage that we support. And it certainly does align with the NDP, healthcare for all. It is absolutely true, Chair, that medical schemes use same benefits in the public sector. But having operated in the industry, let me say why I keep saying the department is not without blame. I'm sad to say this, but in terms of some of the referrals of patients to the public sector, it's not unknown that the referrals could, in some instances, be driven by really just knowing that the government hospitals will not be able to generate a bill. Now, whose problem is that? Who's at fault? When you do have the private sector that refers patients, but they get off scot-free simply because the management system, administration system in hospitals are not there, in public hospitals. It's not ideal, but it's certainly what I've been trying to raise here is that certainly there's a lot that's wrong in the private sector, but in most instances, the only organization or the only player that's sufficiently influential to correct that is government, but it's just not doing it. The medical schemes, are they good for economy? I do say, Chair, that they have played a role. They have played a role. The more relevant question is going forward. And I'm saying from the perspective of transition into the future, we cannot immediately on day one just dump and pretend that there is no value when we do not have plan B to provide the kind of services that we don't always have. But this question can be answered in full once, again, some of the gaps are filled in the NHI bill. What am I referring to? What are the complementary services we talk about? It would help this debate and the questions if you knew which ones those are. I have responded, Chair, respectfully on the question that why are we opposed to funds making investment decisions? We just believed that Treasury is best placed to do this, purely from the skills. That's just how it is. I don't see how a board of 11 people, we already know which sort of skills will need to be there, and those revolve around health management. There is a reason why you need scores of investment professionals to deal with investments. We don't see, we were not convinced that those will be found within 11 people that will make up the board of the fund, not in sufficient numbers. You can have one, you can have two, but not enough to manage administration for a brilliant fund. Am I saying the bill must not assist the poor? No, not at all, Chair. It's in our presentation. I suspect this falls in the question that we actually predicted. I even have in that slide regarding this, where I make the point that we're very mindful that there could be a perception that we are perpetuating the two-tier system, but that only arises if one doesn't look at the nuance. And it revolves around us not saying people must opt out of paying for the NHI. That's not our position. It's never been. And Chair, unless I've forgotten, I believe I've covered the questions that were raised.
Thank you very much, Dr. Bengu, for answering all of those questions. We of course realize it's been a very long walk from 2011 to here. And also, I think I'll take it back to about 2007, but 2011, really all of this work started. And we do know that the people of South Africa deserve universal health coverage. The intention is to provide this to them through the National Health Insurance. We do hear the input of the NPC. We will surely go and have a look at what has been presented, as we will do with all the other presentations and submissions which have been done to date. Thank you very much for that. Maybe you can just give a very short closing remark. I've not allowed the others because we are really running out of time, so maybe 5 seconds.
Is that for me, Chair?
Yes, just maybe a second.
Thank you very much, Chair. No, all that's left is for me to thank the honorable members for hearing us out. And then just to remind, I may have been the face today, but there's a whole team of dedicated fellow South Africans that have given me the input that I presented here today. Also, just to say we appreciate you accommodating us in asking for a postponement, but it was important to appraise the new members of the commission, but not only to appraise, but to take their counsel. And I was able to include that in today's presentation. Thank you very much, Professor Manuliga, for your support. Thank you.
Thank you very much. You're welcome to stay on and listen to the other presentation. We have one presentation left, honorable members. It's way past lunchtime, so we're not having lunchtime. Thank you, Dr. Bing. We are going to listen to the presentation from Scalabrini. And we do have their representative, James Chapman, on the platform. I also see he's already been made a co-host. If you can please introduce yourself and other members of your team, Mr. Chapman, and very welcome to come and do your presentation. Thanks.
Good afternoon, Honorable Chairperson and Honorable Members. It is a real privilege to be presented today. I am James Chapman. I'm the Head of Advocacy and Legal Advisor at the Scalabrini Centre of Cape Town. And I am joined by Father Peter John Pearson, who is with the Catholic Parliamentary Liaison Office, is the director there. The Catholic Parliamentary Liaison Office is our sister organization who have endorsed and support our submissions. Additionally, Father Peter John is a Scalabrini board member. I'm also joined by Chatenda Kaponda, who is in our advocacy team at the Scalabrini Center. and in particular within our Children's Rights Project. So that's those of us who are here with you today. I'm just going to share my presentation, if I may, and we will get started.
Yes, let me also apologize to you for us being late. It is the nature of what we do, but please continue.
Thank you. All right, so consider, medical practitioners, their oath, their undertaking, do no harm, to work to do the best of to the best of their knowledge and ability for safety and welfare of all persons entrusted in their care, for the health and well-being of the community, to not knowingly or intentionally doing anything to administer anything to anyone that will hurt or prejudice, and importantly, to not consider religion, nationality, race, politics, or social standing to intervene between one's duty and their patient, not to discriminate. I mean, we're all kind of aware of the Hippocratic Oath and the requirements to do no harm, not to discriminate upon medical practitioners. But regrettably, we see in the National Health Insurance Bill, there's an extent to which certain categories of people are excluded and not provided that care, that protection from harm. To begin with, just who we are. So the Scalabrini Center's vision is to foster cultural, social, and economic integration of migrants, refugees, and South Africans into local society, perceiving migration as an opportunity. The Scalabrini Center of Cape Town is committed to alleviating poverty and promoting development in the Western Cape while fostering integration between migrants, refugees, and South Africans. And in providing this assistance, we advocate respect of human rights and the use of a holistic approach that considers all basic needs. Okay, just a general overview. I'm just going to be doing an introduction, some submissions, and the conclusion, then open up for question and answer. I also just want to say that we as a Scalabrini Center, we provide direct legal service, direct services, including the advocacy program legal services, but we have a series of other programs, but we look at it from a sort of a very hands-on and practitioner's perspective. So I will be drawing on some examples as well to assist with the presentation. So the bill and its objectives are by and large positive, and we support the steps towards universal access to quality healthcare. However, the bill takes away or removes ways of accessing healthcare services, which include the provision for non-citizens in violation of Section 27 of the Constitution, among other legislative and international law provisions. Progressive realization is required. It's understood. I mean, we're dealing with a social economic right. It's understood and appreciated. But it must be done in a way that you're taking steps forward and not removing or stepping back from the position that is at present. So we're required in terms of implementing the Bill of Rights not to violate the principle of non-regression. The Constitution and a series of legislation are infringed by the bill, and I'll go into detail on that, including the right to equality being compromised, the right to human dignity. There was an instance where a Zimbabwean woman was in South Africa for an inordinate amount of time with her children, and she wasn't able to support herself, support her family. She wasn't allowed to work. She was denied the right to work on an asylum seeker permit. And the Supreme Court of Appeal in 2004 already recognized that Ms. Wachinuka and others in that case had the inherent right to human dignity as enshrined in our Constitution. And that afforded her the right to work, and asylum seekers likewise. And when we're looking at the right to access quality healthcare, as we are in this case, is sort of also tied to the fundamental human right to dignity, and that's something we need to bear cognizance of. Just in terms of a couple of examples, so we have an instance where a young woman fled from Mogadishu, Somalia, because of a war-torn situation, because of persecution based on her beliefs. We have a young man who fled from Eastern DRC because of his political opinion and because he was seen to hold a particular religion, even though he didn't espouse it. These two individuals fled both to South Africa. They both aimed or tried to get asylum documents and have an asylum seeker temporary visa, as is in place now. But they have been in South Africa for 10 years in the one case, 12 years in the other case, without being given formal recognition of refugee status. You have another person who is a nurse in South Africa, another a doctor, another a social worker. All of these individuals are providing a really important role within the sort of care and fabric of South African society. But they are all migrants, all who are on special permits. A special permit holder from Angola, a special permit holder from Lesotho, a special permit holder from Zimbabwe. We have the case of an undocumented migrant child. We have another migrant child who is documented on the documents of a migrant. And all of these categories either are not provided for in terms of the National Health Insurance Bill, or have a limitation or a compromise in terms of provision. And that is what our submissions fundamentally want to speak to and address. So just very briefly, a refugee is somebody who fled on account of a well-founded fear of persecution based on race, religion, ethnicity, political opinion, membership, particular social group, who is unable to obtain assistance from their state. In some cases, even the state themselves are the ones who are the agents of the persecution. You also have people who fled from in a situation where there's a war-torn situation, external aggression, occupation, foreign domination, events seriously disrupting and disturbing to public order. And these are the kind of individuals who ought to be granted refugee status. But I think it's really crucial to note and understand and appreciate that in South Africa, the refugee status determination process takes years, sometimes over a decade. And even though the law required and its initial promulgation was requiring a turnaround time of 180 days, that's not what is happening in practice. And so if you're talking to provision for an allowance for recognized refugees, but not asylum seekers who fall within the definition of a refugee but are not yet recognized, then that's problematic. So in terms of rights, the Refugees Act, particularly protects that asylum seekers and refugees documented or not are protected against detention, deportation, and refoulement. Refugees and asylum seekers are afforded the majority of the rights set out in the Constitution, and I'll talk to that a little bit further. But I also wanted to just point out that in terms of our Refugees Act, Section 27A, it talks specifically to the rights of asylum seekers, and asylum seekers entitled to formal recognition as an asylum seeker, a series of rights, and the rights contained in the Constitution of the Republic of South Africa of 1996, insofar as these relate and apply to an asylum seeker. So we all know that obviously the Constitution is supreme law and protects everyone within the Republic. You see that in terms of Section 9, everyone is equal before the law and may not be unfairly discriminated against. Everyone has an inherent dignity. In the Kosa case by the Constitutional Court and also in the Patel case there, they both speak to that. The wording of the Bill of Rights is clear and expressed that where everyone is used, foreigners have the same rights under the Constitution that citizens have, unless the contrary specifically emerges as such. So refugees, asylum seekers, other categories of vulnerable migrants like your special permit holders are protected by most of the Bill of Rights from the Constitution, as they refer to everyone, and that includes the right to access healthcare. It's important to note that the Constitution, more specifically the Bill of Rights, was meticulously drafted to redress apartheid injustices, and to create a society based on democratic values of human dignity, equality, and freedom. Some of our actual country leaders themselves were refugees and asylum seekers in exile during apartheid. If you look to what Honorable Jacob J. states in the Grootboom case, within the context of housing, but it's can be looked at analogously to what we're looking at in terms of healthcare here. The state should ensure that its policies target the particularly vulnerable who cannot afford to provide for themselves. And we submit that asylum seekers, special permit holders, migrant children, they're all sort of vulnerable groups in South Africa that there should be specific constitutional protection for. The Constitutional Court also has recognized asylum seekers and refugees as a specific vulnerable group in the Union of Refugee Women case that I've given you there. So what about special permit holders? So migrants with special exemption or dispensation permits should be included, as should asylum seekers, which I was speaking to a moment ago, in terms of Section 4.1 of the NHI Bill and subsequent sections that correspond to Section 4.1. Now, most individuals on these permits are, on the special exemption or dispensation permits are low skilled, they're not high income earners. A number of them also are very involved in crucial industries, as I said, social workers, nurses, teachers. Many have, if you're looking at, let's say special permit holders, many have fled or left circumstances of poverty, humanitarian crisis, failure of governments to provide for their even most basic needs. So they've left from a situation of starvation in some cases. They constitute a vulnerable group. And during the pandemic, special permit holders were actually recognized and had access to the relief from distress grants, mindful of the vulnerability of these persons and their need for relief. Obviously, asylum seekers are also included and recognized for that vulnerability. Special or exemption permit holders also by and large have been in the country for a substantial period of time, and they've made a substantial contribution to the fiscus, to the fabric of society. Many, as I said, are nurses, care workers, teachers, and social workers. It does not make sense to exclude such individuals from the bill, beyond the fact that to do so would not only be nonsensical and unwise, but it also would fall foul of the Constitution and would be retrogressive in its application. It's not enough in the law that also, because one might say, but what about Section 4A saying, well, additional categories of migrants may be provided for at the discretion of the minister. The law is quite clear that, it's not enough for the minister to merely have a discretion for to include maybe special permit holders or asylum seekers, but they must actually be expressly included as a category. And I'll give you authority for that in terms of the Dawood versus Minister of Home Affairs case, where the Constitutional Court held that it's not sufficient to rely on the assumption that discretionary power applied in a way will be applied in a way that is consistent with the Constitution. Moreover, actually, if we take a deeper look into the NHI bill itself, it actually separates and places asylum seekers in an alternative category with very, very minimal provision of health services. So progressive realization. Some of the former speakers have also spoken to this a bit, but the Bill of Rights talks to this, and everybody is granted the right to access the rights and duties placed upon the state, and the state is required to take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. And despite the right to have access to healthcare services being guaranteed in the Constitution, access is not always universal from the beginning due to resource constraints. And actually, the former speaker also spoke to a case that I was also thinking to speak to, the Subramani case, which really sort of clearly paints the picture that regrettably, sort of kidney dialysis is not available to each and every person so choosing. And if it were to be, then it would be compromising other medical provision and services. However, both the Constitution and the UN Convention on Economic, Social, and Cultural Rights recognize that while this is a reality, the rights have to be realized over time, and progress towards full realization is dependent on availability of resources. Now, if we sort of review what adequate in terms of what adequate measures are to be taken, we also need to bear cognizance of sort of a core aspect of scarcity and the need to prioritize and focus on the marginalized, the vulnerable population groups. And this is unfortunately not what we see in the current iteration of the bill, in excluding, as I say, special permit holders, undocumented migrants, children, asylum seekers. There's also just a reference there with respect to progressive realization. Talking specifically to the right to healthcare, asylum seekers and refugees have the right to the same basic healthcare and emergency care services as South Africans, as do, as I say, special permit holders, the undocumented. If we look at Section 27.1, and I go quickly through this because you're very well aware, but just to mention, as I mentioned in the constitutional case of the Corsa and others, it states everyone has a right to access healthcare services, including reproductive healthcare. And then we talk to progressive realization of the right in terms of subsection 2 there, and then nobody may be refused emergency medical treatment. This includes anti and postnatal care for pregnant and lactating women. That's a quite important point there, because depending on the interpretation of the bill in its current iteration, that also might be even further restricted in the case of asylum seekers. So if we look at the rights of asylum seekers, special permit holders, refugees, the well-being of asylum seekers, refugees, and special permit holders is intrinsically challenged by ill health. I mean, we can see that in terms of their journey from their country, whether you take the case of a special permit holder who might have fled because of abhorrent conditions, starvation, poverty, or somebody fleeing from violence and persecution, hunger, exhaustion. They have increased vulnerability. Then also before leaving their country, some of them might have been victims of armed conflict, suffered from displacement, violence, torture. And these issues often give rise to poor health and a great need for health services. We also must need to acknowledge that in terms of international law, the 1951 Geneva Refugee Convention, the 1969 African Union Convention with respect to refugees, and indeed our Refugees Act, we have obligations to protect and provide host surrogate protection to the particularly vulnerable group of individuals, being asylum seekers and refugees. And that includes the provision of health services. In terms of the right to healthcare, there's also a very clear sort of circular from the National Department of Health issued in 2007. And this was developed confirming that asylum seekers and refugees, both those documented and undocumented, should have access to hospitals and not be charged the fees that just as South Africans are assessed on a sort of a means test. Undocumented asylum seekers also should receive treatment. We see refugees, asylum seekers having access in terms of the circular to HIV, voluntary counseling, testing, ARVs, and actually the kind of exclusion of asylum seekers from Section 4.1 of the bill is in conflict with this circular. It's retrogressive because it's taking away from the current position that it has in place, and it's unconstitutional violation of the Constitution, particularly Section 27. One of the previous speakers from the SA MRC also mentioned something, and I quite like how he put it. He talked about sort of unhealthy people place an unnecessary burden on the healthcare system. And we'd submit that, if you are to take away care except where it is required for public health, safety, or where it's an emergency, from special permit holders, from undocumented migrants, from asylum seekers. What in essence would result is that the more minor or less serious conditions would have to, go untreated, uncared for. And only when things got very serious and there was an emergency situation, which is a lot more costly to the health system, much more burdensome to address, would have to then step in and address it. Whereas a lot of matters at a much lower cost could be attended to if there was a much greater access and provision provided for in terms of the bill. There is just a copy of that 2007 circular that I spoke to as a point of reference. All right, I'm also happy to share this after this. If you're talking about forced migrants, asylum seekers, and refugees, the principle of non-refoulement is like it's a French word. It's a bedrock of refugee law. It requires that nobody may be denied entry, returned, or sent from a country where their life, liberty, fundamental human rights would be at risk. And it's protected in terms of the 1951 and 1969 conventions. It's also codified in our law in terms of Section 2 of the Refugees Act. And I raise the principle of non-refoulement because the bill as it stands actually risks violating this non-derogable fundamental principle of refugee law and refugee protection that our state has an obligation to protect. Because if asylum seekers are forced to leave the country because they can't access healthcare, that in effect amounts to constructive or indirect refoulement, and sending people who might be forced to return to an environment where they would be incarcerated without trial, or to an environment where they would be tortured, persecuted, even face death. And so this is a very serious thing, the violation of this principle. And then if you talk to sort of economic migrants, by way of comparison to your asylum seekers, and to emphasize the vulnerability, such individuals could return to their country. Similarly, South Africans, we have passport holders, again, they have that flexibility. But asylum seekers, refugees, people who are forced to flee because of a well-founded fear of persecution, or people who are forced to flee because of a war-torn situation, don't have that privilege. They don't have that option to return. Now, I also just speak to Section 12.1, because again, the right to freedom and security of person is extended to everyone. And that includes the right not to be treated or punished in a cruel, inhumane, or degrading way, and having the right to bodily and psychological integrity are also really kind of crucial things. And then, I mean, we are all aware in terms of the rights of children, Section 28.1 C. I've just highlighted there in particular in terms of every child has a right to basic nutrition, shelter, and basic healthcare services and social services, protected from maltreatment, neglect, abuse, or degradation, and that the best interests of the child are paramount importance. And I'll come to why I'm mentioning this in just one moment. But before I do, I also just want to note a sort of a parallel right in terms of progressive realization. If we look at the right to education, there was not too long ago, back in 2019, a judgment, a High Court judgment in the Eastern Cape that talked to a situation where children were being denied access to schools and the rights of childhood, constitutional rights in Section 28 were severely compromised. And so the Center for Child Law and the Pakimisa High School and others went to court to challenge that. And the court found that migrant children could not be denied access to schools based on a lack of documentation or lack of documentation for their parents. And I raise it because similarly, we need to provide for and ensure that there's proper protection and care for another progressively realizable right in terms of healthcare. I also mentioned that following on from that case, the Department of Education actually circulated a circular making it very clear to all schools or all institutions of that right. And if the National Health Insurance Bill remains in its current form, then it is at serious risk, particularly as it doesn't meet constitutional muster, of being challenged, and then having to find a kind of a similar judgment. Whereas if the bill is amended and adjusted to take cognizance, particularly of these vulnerable categories, that's a crucial step that ought to be taken. Now, coming back just a little bit closer to the bill itself and to what I've been speaking to before, we do see, and on a quick and ordinary reading, it says in terms of Section 4.3, all children, including children of asylum seekers or illegal migrants, are entitled to basic healthcare services that are provided for in terms of Section 28(1)(c) of the Constitution. But you'll note that children, particularly children of migrants, asylum seekers, illegal migrants, which is provided for as a separate category in terms of Section 4.2, are not included within Section 4.1. Section 4, and that's the point I've made there, the children are not a group mentioned in terms of Section 4.1, for which the fund, in consultation with the minister, must purchase healthcare services determined by the Benefits Advisory Committee on behalf of, because these are the particular provided for categories: South African citizens, permanent residents, refugees, and as I say, it's very important to note that asylum seekers are not mentioned there. Inmates as provided for in terms of Section 12 of Correctional Services Act. Certain categories of individual foreigners determined by the Minister should be the Minister of Health together with the Minister of Finance by notice in the Gazette. And it's crucial that the point I raised previously, and I think I might raise it again further, that having it's in the Dawood case, having the mere discretion doesn't mean that the constitutional irregularity is just wished away, or that the decision maker, in this case the ministers here, will make specific provision for vulnerable categories like asylum seekers, like individuals incarcerated facing deportation who have a valid and genuine basis for being in the country, like migrant children, like special permit holders. And likewise, as I already said, Section 4.1 does not talk to the inclusion of dependents of identified categories, asylum seekers, illegal migrants that are provided for in terms of Section 4.2, or even those of refugees. So that's that there. And then I also wanted to just touch on identification, documentation, and access, because if you look at Section 5.5, it says when applying for registration as a user, the person concerned must, and it provide biometrics, fingerprints, photographs, etc., and an identity card as defined in the Identification Act, a original birth certificate, a refugee identity card used in terms of the Refugees Act. Now, working particularly in the sector with people on the move, with migrants, asylum seekers and refugees in particular, unfortunately, the refugee status determination system, the refugee system, is not efficient. It is not processing asylum claims timelessly. As I mentioned before, it can take a decade. It can take more than that, sometimes 12, 15 years before one is recognized as a refugee. And so up to that point, they won't have these documents. Even once one is recognized as a refugee, Under COVID, there are these online refugee status document, but there's no refugee IDs or refugee passports being issued. Even when those were being issued, they'd sometimes take over a year to be issued to a recognized refugee. And so I just wanted to caution and mention that this particular provision requiring certain identity documents is problematic and not practical, and would if strictly implemented, would compromise the access. So yeah, as I say, documentation is limited, and the categories of documentation should be extended, mindful of the series of challenges in obtaining identity documentation. And the absence of identity documentation should not compromise access to healthcare services. If I take us back to our examples, if you look to the person who fled from Eastern DRC, the Great Lakes region, an area where there's mass gender-based violence, where there's political persecution, religious persecution, somebody who fled to the country and wants to apply for asylum, if somebody is in such a situation, they would not have been able to do so for in excess of the last 2 years, because all refugee reception offices have been closed. And even before that, if they came maybe 3, 4, 5 years ago, refugee reception offices had enormous backlogs, were not receiving asylum applications to the masses. They were giving a small sort of slip of paper saying, come for an appointment. And so you have an enormous number of people who are vulnerable, who are supposed to be protected in terms of our law as people with genuine refugee claims, but don't have documentation, and surely are not the individuals who ought to be excluded from the NHI. Yeah, so as I mentioned, the closure of refugee reception offices, leave people undocumented. Also requiring a birth certificate. There are huge difficulties faced by South African nationals, by migrants, in obtaining birth registration documents. Birth certificates, the late registration of birth is an enormous nightmare. Recently, the Scalabrini Center did research finding that there are thousands of South Africans who can't access late registration of birth and get birth registration documents for their children. There are likewise migrants, asylum seekers, refugees who cannot get birth registration documents, and that being a requisite to register is hugely problematic. I wouldn't say that this is not something that should be addressed. In fact, it should be addressed. And one of the real saving graces and a really positive step that was taken by the Department of Home Affairs was the extension of birth registration to 12 months as opposed to 1 month. Allowing for 12 months in order to get registration of birth, but there's still a steep uphill battle in terms of that, and huge challenges with documentation. So I would just flag and raise it as something that needs to be addressed. And in conclusion, the bill with respect to categories provided for is not in line with the Constitution, nor with other legislation, international law and our international obligations, or with the jurisprudence of our courts. And should be adapted accordingly. The bill should be amended to make express and clear provision for asylum seekers, special permit holders, minor dependents of migrants, expressly revised in terms of Section 4 and other relevant provisions. I've spoken specifically to Section 4 because that talks to the access categories there. This should apply for those who are documented, and should not only apply for those who are documented, but it should also include undocumented asylum seekers. Apologies, there's a typo there. The bill takes away access to healthcare services from asylum seekers, certain categories of children and dependents, special permit holders as citizens of SADC, and other undocumented migrants. It's unlawful in this respect, unconstitutional, inhumane, and it's not in the public health interest. The bill is even in conflict with its own objectives in terms of universal health provision, equity, solidarity. These are compromised by excluding these vulnerable categories. Thank you for the opportunity to make submissions. I'm happy to address any questions that may be raised.
Thank you very much, Mr. Chapman, representing Scalabrini Center of Cape Town. for your presentation. Honorable members, I'm looking at the platform. I have 2 members so far want to raise questions, Honorable Skela and Clark. Any others, please shout on the platform now. Honorable Sukacha. Any other members who want to ask any questions? Honorable Geller, please continue.
Thank you very much, Chairperson. Let me welcome the presentation done by Mr. James to the Portfolio Committee. My question, in the face of a physical constraint, how do you propose government should mobilize funding for healthcare for both documented and undocumented migrants without compromising funding for citizens? The other question, my second question, Chairperson, if you allow me, what is the message from Nhi Bill conveyed to the Department of Home Affairs and other relevant departments as the health sector bears the brand of lack of enforcement of maintaining the integrity of the population database of South Africa? Thank you, Chair.
Thank you, Chairperson. I've just got one question that I would like to ask. Considering your view on the bill having some clauses being unconstitutional, do you foresee the bill being successfully implemented in its current form? Thank you, Chair.
Honorable Sukacha.
Thank you very much, Chairperson. Let me also welcome the presentation. Just 2 questions from my side. The first one, Chair, would Scalabrini be in agreement that the health sector should assign certain forms of identification to illegal immigrants and link this to law enforcement agencies should the proposal that is made to be accepted? In countries such as France, their entitlement is linked to their information being linked to law enforcement agencies. And the second question, Honorable Chairperson, will Scalabrini support enforcement of closure of South Africa to political and asylum seekers through interventions of the security cluster? Or is Scalabrini supporting the current situation where the borders are porous? Thank you very much, Chairperson.
Thank you very much. Any other members who want to ask any questions? Mr. Chaplain, I see you make quite a strong case for what you call vulnerable groups of persons, and that you actually define them in your presentation, and that you're making, emphasizing that these specific vulnerable groups need to have access to health care in South Africa under the NHI. And that you're actually stating that these non-South Africans, or you have a view rather, who are in the country will not have access to healthcare services under the NHI. I'm not sure exactly where that is reflected in the bill, so if you can give me clarity on that, because I am referring to Chapter 2 of Section 4 of the bill, where provision is made for services to be accessed by asylum seekers, illegal migrants, and foreign nationals. So I would like some clarity with regards to the statements made in slide 3. And then secondly, the Constitution states that access to healthcare is available to all who live in South Africa and does not specify citizens. The only right that is unique to citizens is voting. What is your interpretation of this constitutional prescript juxtaposed to the Refugees Act? And then are there any international best practices that can be emulated by South Africa to mobilize additional financial resources? Because we must really be certain here that if we look at some of the complaints which are raised in some of the provinces up north, it speaks to sometimes to people coming purely to access healthcare services. And so what would be the constraint on our fiscus in that regard, for example? Would you therefore support South Africa expecting that countries from which the migrants are coming from should be levied? This could be done through a SADC or AU or a UN mechanism. And should South Africa be expected to go to the multilateral platform to source funding like other recipient countries do? Now, Section 6.4.2 of the bill provides that asylum seekers or legal foreigners are only entitled to emergency medical services for notifiable conditions of public health concern, while offering NHI free comprehensive services to non-legal residents and asylum seekers, not encourage the healthcare motivated migration, which is the one I was speaking to earlier. Honorable members, are there anyone of you or any of you who would want to still raise any questions to the presenters?
I'm covered. Thank you, Chairperson.
Chair, may I?
Honorable Ismail, please continue.
Thank you. I just have two questions. You know, in a presentation by the Lawyers for Human Rights that actually came to do the submission and presentation to us, there was mentioned that a study in Europe showed that extending access to healthcare migrants resulted in savings of direct and indirect medical costs. Would you agree with this study? My second question, would you view the bill as it stands potentially xenophobic in its type of inclusion or exclusion of asylum seekers and or refugees? Thank you, Chair.
Thank you very much, honorable members. Mr. Chapman and your team, you're very welcome to give us responses to the questions which were raised.
Right. Well, thank you very much, Honorable Chairperson and Honorable members for your questions. I will address each one in turn, and if there's anything that I haven't covered, I would just ask my colleagues to add in. The first is in terms of the constraints faced, the need to mobilize funds. I mean, if we're talking about the migrant populace, data suggests that it's maybe as much as 4% of the population in the country. If you're talking about what of that population is unhealthy, it's substantially less than that. In terms of if you regularize and treat and address things in a proactive way, individuals in a proactive way, in a way that affords dignity, you actually are going to be saving costs I can use the example of the vaccine, COVID-19 vaccine, that is extended to undocumented street people in South Africa, and to undocumented migrants, and to migrants with expired documents, because in order to address the sort of public health concern effectively, and to really address the medical situation, it was required to have an inclusive approach that includes all categories, because otherwise you're not going to effectively combat the pandemic. And similarly, so to effectively address health problems, you need to be inclusive, particularly of your vulnerable categories. It's also not all individuals who will be in that, somebody seeking asylum having fled from a well-founded fear of persecution, or somebody who has a special permit that's been recognized by the department, and have that degree of vulnerability. So it's a very small grouping. In terms of enforcement of the law to maintain South African society's integrity, if that's speaking to leaving or removing your migrants or mixed migrant flows, that's a very problematic position. As you can see in terms of our overarching objectives of organization, we see migration as an opportunity. I would support, just in relation to that the last honourable speakers mentioned that research in Europe, and there's research also coming out of Canada that supports that a populace where healthcare is adequately and properly provided for is actually less burdensome on the economy and the fiscus. We also will and have continued to sort of come alongside and work with the Department of Home Affairs, and in some cases, unfortunately, one has resorted to strategic litigation to ensure that people are regularized, they are documented, because a documented migrant, whether you're talking about an asylum seeker or a refugee, a special permit holder, or any visa holder, is in a much better position to make a contribution to society, to the community, to the fiscus, which in turn will be very beneficial in terms of the National Health Insurance Fund. Would I say that the bill in its current form is unconstitutional? Yes, I would. Does that mean that it would necessarily be passed? Unfortunately, there are instances where unconstitutional legislation is passed. We can see that in terms of certain aspects of the Refugee Amendment Act with respect to the Refugees Act 130 of 1998, which was passed into our law and came into effect on the 1st of January 2020. But there are a series of provisions there that fall foul of our Constitution and fall foul of our international law obligations. So yes, I do think that the bill in its current form, because of the excluded categories, doesn't meet constitutional muster. I think that this might be a good juncture also to address the chairperson's question about how we're saying they're excluded, but there is provision. It's the limitation of that provision. If you look at Section 4.2, in the case of asylum seekers and illegal foreigners, where it talks to only giving assistance where it's in the public health interest, or where you're dealing with emergency medical conditions. So take the case of a asylum seeker from the DRC who's married to a South African national and is to deliver and give birth to her child. That asylum seeker, provided sort of natural birth, no complications, wouldn't have access to healthcare. Despite marriage to South African, despite the child to be born being South African. A situation where, as one of the former speakers spoke to, somebody with sort of minor conditions that you can sort of try to prevent or address initially can escalate to much more serious matters if there isn't proper provision to basic and proper healthcare services to asylum seekers, to vulnerable migrants. Then when it comes to the supporting, do I support the security cluster and the perspective of closing the borders and making them less porous? And it's something that has been addressed in a lot of states, not only the South African, not only South Africa, but countries in the region and internationally face difficulties with regularizing migration. And I think that instead of speaking for trying to foreclosure or enhancement of fencing or that kind of thing, one should rather look to seeing, what protections do we have in place? Can we regularize migration so that we stop and avoid the risk of human trafficking, the risk of abuse and exploitation, the vulnerabilities of individuals who are undocumented, which are far greater than those who are undocumented. I mean, our courts, just give you the example in terms of the Mubake case, the courts recognize that even if you're dealing with a child who's a victim of trafficking, a child who is in really egregious circumstances, if they're documented, if they're regularized, that gives them a modicum of dignity, a modicum of protection, a much better position in law and in practice than had they not been documented. So my argument and my submission would be that instead of sort of a wholesale approach of trying to just close a door or fence or a gate, which in reality is not feasible, and in a lot of cases the attempts at implementation are not humane, but also they're not going to address what would be beneficial, which would be the regularization and improvement of the position through the documentation of individuals. And so that's what Scalabrini Center would rather support. And then in terms of the Constitution speaking to everyone, it does provide for everyone. There's only certain limited circumstances where everyone is not provided for, and so it is our very clear and frank submission that in accordance with the Constitution, the National Health Insurance Bill should make allowance and provision for everyone, as is provided for in our Constitution. But it falls shy of it in its current iteration, particularly if you look at Section 4.2. In terms of galvanizing financial resources, particularly where and trying to maybe avoid medical migration. So I mean, the two things in terms of resources, like resources can much more effectively be used if you have regularization, but if you have the provision of medical assistance from the first instance, if migrants are included within those, that there is preventative information sharing campaigns, provision to avoid whether you're talking about your communicable or non-communicable diseases, if you're talking about, as we talked to, one of the former speakers talked to you, sort of cancer, tuberculosis, where we, if we were to address this at the first instant and be all-inclusive, we'd be in a much better position. And we can also see that with respect to communicable diseases, whether you're talking about the current pandemic, whether you're talking about HIV, AIDS, I mean, we're in a much better position if you act in the interest of public health and include the whole of society, include people on the move, rather than excluding or avoiding all except for a very small group in the case of refugees. And I appreciate that refugees are provided for in the bill. I just think it should go much further than merely recognized refugees. And then, as I said, the provision for and ensuring that the health of the migrant populace also is beneficial, because a healthy migrant population is a potential working population, a population that in terms of their purchases, they contribute through VAT and sales tax. In terms of their employment and work, and employing a lot of South Africans as well. And we've seen that a lot of migrant-owned businesses hiring a lot of South African nationals and adding to the economy, adding to job creation. and improving the situation. And that can only be garnered if you ensure that the health and well-being of the migrant populace is also protected and taken care of. And so, as I said, it should go beyond that emergency medical and public interest, public health perspective. And then, do I see that the bill or do we see that the bill as provided could be construed as potentially xenophobic through its exclusion? I mean, yes, that's an argument that could certainly be made. Yeah, it is problematic where there is any unfair discrimination that takes place, whether it be a bill, whether it be an iteration, whether it be xenophobic violence, any instance where we see the unfair discrimination against an individual based on their race, based on their social standing, based on their nationality. Afrophobia is a real reality in South Africa, xenophobia and Afrophobia. And it's something that needs to be addressed. And it's not something that we should be endorsing and actually promulgating in our legislation. In terms of, the health services should be extended to migrants. I think I've covered the majority of the questions. I'm just checking, is there anything you wanted to add, Father Peter John?
Thank you. I do believe that you've covered everything very well indeed. I think we would want to say from the Church's perspective that we are particularly concerned with the special permit cases. And again, in terms of generating financial flows, people who've been here for 15 years and longer, who are in some instances, in most instances, paying tax, but certainly contributing through sales tax and VAT. I think we need to take that into account when making too broad an assertion that they are not contributing any more than, or any more than South Africans are. So we want to support that. I think we are very concerned, and people working in the faith communities across the board have pushed recently very strongly for examining regularized migration and ensuring that the pathologies that go with dangerous migration and unregularized migration should really be minimized and abolished, and that is in fact one of the best ways of border control. We worry about how language in bills which in themselves might not be inflammatory, taken against the current emergence of a narrative that promotes xenophobic responses and political discourses that inflame that kind of reaction. We worried that even innocent exclusions can, in the uncritical mind, be another cause of xenophobia, Afrophobia. But we want to support the bill in its broad aspirations, but certainly want to have further discussions around the issues that we've raised in our contribution today, and hope that this discussion can continue, because we think there are vital ways of ensuring that public health becomes one of the banner projects for a more socially cohesive and healthy society. Thank you.
Thank you very much to both of you for coming today and coming to do this presentation, and also for your responses to the questions which were raised with you by the members of the committee. I think we have come to the end of the day. If you maybe want to make a very short closing remark, and then we will be adjourning our meeting.
Just to say thank you very much to you, Honourable Chairperson, and to all the members for the opportunity to come and make submissions. It's sincerely appreciated. Thank you, and all the best.
Thank you very much. And thank you very much. Same to you. And honourable members, we have come to the end of today's work. We thank you for being present today. We thank all of the presenters for this entire day. It's been not 2 days, I must say, but yes, one gets through everything. So thank you very much. This meeting is then adjourned.
Thank you, Chairperson.
Recording stopped.